Ejabuze.
Next slide. No, because the presentation is 10 minutes. What is it? When I'm presenting, when I do this, you change.
Okay. Yeah, that is okay. Nabadde ndowooza n'ogamba nti kati making from ayagala ate tebajja kujja bajja era oli omu okujja jja hello Brian feedback gambe etaano kate njagala delivery nno njagala delivery wano ku golf course
We are now starting conference activities. May you have your attention and please follow the program as it is in the book.
Kaseddemu naye kale tugendera.
We start with one prayer. Okay, please come up.
Hello. I got one. Then I call it energy. Midwives. Like Nina, okay, Nina, but I love it with a midwife. I'm going to do that just organized.
As the conference chair, by the name of Dr. Kazima Lawrence, an obstetrician, gynecologist, clinical head at National Hospital, and the Association of Obstetricians of Uganda member. I take this opportunity to welcome you all to this conference. Kindly feel at home. Let's pay attention and try to learn. Get as much as you can for the research that will be shared, the papers that will be shared here, the works that are being done in our institutions. I pray that it will be a little tool to go back and improve the level of care that we do offer at our institutions. Without wasting a lot of our time, I know the program is quite packed. I pray that we keep time with the presenters and please pay attention to our program. And wait to the delegates. Finally, the presenters, try to look at him as he warns us on the time the 10 minutes. And when the flasher is saying stop, please stop. I hope we have it there. Also, for the microphone.
Audio.
So session 1, let me introduce the chairperson of session 1 for this conference. Dr. General Rogers, you most welcome. Please come and take us
It is not possible.
Thank you very much. expecting a response. Good morning, ladies and gentlemen.
Good morning.
Yes. We are going to have our first session, which I will chair. Dr. Kazi was rightly introduced me as Dr. Rogers Kajamandu. I am from the Department of Obstetrics and Gynecology, University, Banana Regional Reference Speaker, and I am happy to chair this session on adolescent and teenage pregnancy. So right now I'd like to invite the speakers in this session to come and take up their seats. Dr. Henry Chiza, Dr. Patrick, Dr. Vincent Mwangizi, and Dr. Peter Susan. Please come and take your seats, and then we will have the first presentation from Dr. Chiza. After all my speakers have taken their seats, I will introduce the first speaker.
Like the number things which is not that young.
Henry.
I assume all the presentations are already with the IT team. So this will be the order of the presentations. Dr. Henry Chiza will start, followed by Dr. Vincent Mwangizi, Dr. Peter Susan, and then we will have a representative from former one of the pharmaceutical companies. So each speaker will have 10 minutes, and speakers, I request you to keep the time so that we keep on schedule. So right now we are going to have Dr. Henry Chiza, who is a specialist obstetrician and gynecologist from the Department of Maternal Fetal Medicine at Mulago Specialized Women Mental Hospital. He's also a research fellow at the School of Public Health at Makerere University. Ladies and gentlemen, let's welcome Dr. Henry Chiza to share his presentation with us.
Thank you so much, Session Chair, the organizers of this conference this year. All protocol observed, I have been introduced by the name of Chiza Henry, and presenting research findings from a study carried out at Mental. Factors associated with depression symptoms among pregnant adolescent girls and young women. And my co-authors are Dr. Christine Nawanda and Dr. Daphne Namasi, both faculty at the School of Public Health. So that's my presentation outline. That's how it's going to be. So introduction, depression symptoms during pregnancy affect about 1 in 4 women worldwide. And depression symptoms among pregnant adolescent girls and young women is often undiagnosed and untreated most of the time during the menstrual period. And usually when these adolescent girls and young women experience stress in the form of psychosocial and physical stress, this makes them prone
At the entrance.
of depression symptoms. Depression symptoms during pregnancy is a concern because it affects health-related behaviors and pregnancy outcomes. So, a cross-sectional study was carried out at Awente National Referral Hospital, and where the participants were selected, this is systematic random sampling technique and modified household regression analysis as used. So that is the participants' social demographic characteristics. We are sorry we could not get a value on that. So hopefully we can get greenhouse. But otherwise, what we found was that the adolescents, that is 15 to 19 years, 15 to 19 years were about 17.5%, while the young women, 20 to 24, were 82.5%. And the majority of them were presented in the third trimester, that is 49.2%. So the prevalence of depression symptoms among pregnant adolescent girls and young women attending adolescent antenatal clinic at AOGU was found to be 19.1%. And that guided us on the depression analysis method that we used. That was transformed. It was already about 10%. We also found that adolescent child had slightly higher prevalence of depression symptoms at 21.9% compared to the young women who found it to be at 18.5%. This is close, and that probably explains why these adolescent and young women are together. So they share a lot of pointed to that. We move on. So the factors that were found to be associated with depression symptoms among these age groups was we found that the prevalence of depression symptoms was twice higher among those who had 3 or more pregnancies compared to the prime gravidas. And we also found that depression symptoms was 3 times higher among pregnant adolescent girls who ever experienced partner violence compared to those who never had such an experience. And we also found that depression symptoms were 2 times as high among those who reported low perceived partner support compared to those who had greater partner support. The other factor was that pregnant adolescent girls and young women who suffered from COVID-19 symptoms had a 2-fold prevalence of depression symptoms compared to those who never suffered from the pandemic symptoms. And we also found protective factors to be a woman, a pregnant adolescent who is a housewife, that had a protective effect of about 50% compared to those who were in formal employment. We also found that self-employment by pregnant adolescent girls and young women conferred about 60% protection rate from depression symptoms compared to those in formal employment. Move on. So that is the table showing the multivariate analysis for the factors associated. So the conclusion was that the prevalence of depression symptoms among pregnant adolescent girls and young women attending antenatal clinics at Kawempe was 19.1%, and the factors associated were pregnancy for the 3rd or more times, low partner support, experiencing partner violence, and suffering from subjective COVID-19 symptoms, and self-employment and being a housewife was protective. So our recommendation, we recommend that we offer them vocational skills, sexuality education, and age-appropriate messages. And we also think that postpartum contraception discussions with postpartum mothers should include broader strategies rather than just talking about the methods. We need to go deep and find out strategies to prevent or delay repeated pregnancies, and also involve adolescent boys and young men in issues of sexual, reproductive, and maternal health maternal health, and pointing out specifically dangers of early fatherhood to this group of men, and also to advocate inclusion of routine depression symptom assessment of pregnant adolescent girls and young women in the national antenatal care policy. Thank you very much.
Thank you very much, Dr. Henry Cheza. Next, ladies and gentlemen, is a family physician. Think about these people as all-round doctors. Dr. Vincent Mubanjeze is a family physician in the Department of Family Medicine in Barara University of Science and Technology. Please come and take us through antenatal couples counseling to improve uptake of birth planning and postpartum family planning.
Thank you for the introduction. Ladies and gentlemen, thank you for allowing me to make this presentation. The presentation I'm making is a study being done in Mbarara. It's ongoing, and we have this one member of the research team is here, Dr. Marin and others. And this study, we are trying to, it's antenatal couple counseling to improve uptake of birth planning and postpartum family planning. This is a feasibility trial study. In order to put why we did the process evaluation, allow me first talk about the background of the study briefly. Confidential inquiry into maternal and the and child days found that at least 20% of under 5 days could have been avoided by use of contraception to prevent unwanted or unplanned pregnancies. And also 25% of these deaths could be prevented by ensuring mothers delivered at the right place. Next. And so lack of family planning and the birth planning are important avoidable factors in maternal and perinatal deaths in Uganda. Next. So the project aims to develop pilot and test the feasibility of a trial complex community-based intervention to reduce maternal, perinatal, and neonatal deaths. It's funded by MRC UK. And it has the components, basically, is we trained VHT teams. We have the participating health centers, they are 4, 2 control, 2 intervention. And at the health centers also developed health education films on postpartum family planning. We did a training package for midwives and nurses on how to do effective couple counseling on birth planning and postpartum contraception. And also we are paying the midwives for the extra time so that even they work over the weekends and public holidays. The intervention design is that these films, health education films, were developed using a person-based approach and they were approved by the Ministry of Health to be shown. For the refresher training package, we used materials by the Ministry of Health and Uganda Sexual Education and Pastoral Education. This project was done in Kanungu. And also the training package on counseling, we basically used materials from Ministry of Health and CDC, Global Health Program. So this is a cluster randomized trial, I've already said that. Next. And so at each health facility, we have 10 VHTs who cover the catchment area and the health facility. And these VHTs identify pregnant mothers, screen them for inclusion, they consent them, and they collect data using a Cosmos app on their smartphones. Basically, this slide shows that they do. There are 5 visits they conduct. Next.
It's still to do that.
At each visit, For all groups, they collect the information on family planning and bus planning intentions and actual use. And also,
when they talk about family planning, sometimes because domestic violence, social work programs and domestic violence to ask if they have experienced it, and each sort was related to family planning. And for intervention groups only, they were engaged through some councils of the purpose. And also talk about bus planning and postpartum family planning. So the purpose of this evaluation was to understand the mechanism and the context of successful and unsuccessful factors affecting our intervention. So we used a quantitative study alongside the cluster and the purpose is we selected the participants. These were the executives who delivered the intervention, the managers and the fathers, those who accepted advice and those who do not, and the health workers. Interviews were conducted by such staff not connected to the study to avoid
Yes,
bias.
what's what?
The interviews were recorded,
Same by Jackson umuntu yakatiki.
using the guys. So what were our findings of these 7 interviews? 16 participants, these included 10 men and 6 women. 10 women and 6 men. These were the husband of some of the people included. Then we give executives, get skills, health workers and working managers. This might also come from the other inside. So for one, in some of the research guidelines, successful outcomes were training executives and health workers gave couples an opportunity to discuss bus planning and postpartum family planning and to help them reach a joint decision. For example, staying to me, the best helped us make a decision by giving us information. So in the end, we made a positive decision. But if you are not that, I've been living annoyed by this time. We found that children are human, when they use the letter pregnancy, sometimes they use it outside the day and also cause the sample children and conflict in the family. But when they discuss it, it becomes good. Also used by executives against workers, and the executives and health workers being available all the time, enabled more couples to access the services. The sexual, the ASC, that's the medical appointment, was like for 24-hour service. Anytime a client would come, some people would come in the evening at 6 p.m. and you are available to give the services. From the weekends, even for Sunday. So we are giving them services needed no matter the time. Maybe these health facilities are all public health facilities, but you know that family planning in reality, most of the facilities is done at specific time of the day. Men fail to go when you have come to health centers. You know, I've been struggling to have men go to health facilities. But you have the question to ask at private things. When they come, what do you do to them? So this time they fail to abandon, and also men fail to empower the youth family planning when supported by husbands. When the case told us, me who said that I can use the IED, since the impact I don't want to use some challenges. Maybe if there was a man who said the series and impact. Reasons underlying unsuccessful outcomes, women should be still a big issue for volunteers and social volunteers. Some don't believe that using a method is kind. What? They quote that famous verse in the Bible, go and my cry and in the house. Others say it's not that Israel and so on. And social norms they exceeded. There is one more for many people, that's why they get. Attitudes, skills, side effects, and misses, still a reactive. And lack of time. Most of the time, they will talk about the side effects of bleeding, what's causing for some time. So the man will say, if I put my wife on family planning, you have a sexual problem, and then I start sexually. And supportive husband. Sometimes the woman wants the husband not to do the supporting one.
were suspended. Even when we had not yet become sick, we were telling the clients, if you are not sick, don't come to health center unless you have a serious issue. And what they meant by serious issue, that one depends on them. That's when you should come to health center because the COVID-19 positive cases are many. Next. Conclusion and way forward. Intervention functioned well in the presence of supportive husbands, good collaboration between VHTs and health workers. By supportive husbands, we found when we are going to promote family planning, please remember the husband. Don't only think that since the woman going to use, you remember there's another one who is a very important person. There should be a good collaboration between the VHTs and health workers. And also, we are, as we forward, we are looking for funding and collaborators to expand our intervention to move from the pilot to a bigger area. Thank you very much. As an acknowledgement, I want to acknowledge our colleagues and the funder and the participants, plus the Association of Uganda, Association of Obstetrics and Gynecologists Uganda, for allowing us to present our primary thing. Thank you very much.
A bigger hand clap for Dr. Mwanjeze. Our next presenter is slightly younger than those who have come before him. He's called Dr. Top Patrick. He's a resident in the Department of Obstetrics and Gynecology at Mbarara University. Dr. Top is going to tell us how the hospital in Mbarara managed to continue providing services during the COVID-19 lockdown, a period we all remember vividly. Please come and start your presentation, Dr. Top.
Change your presentation. Just give it. Wait, I told you what is it. You can go.
Protocol observed at various capacity. Good morning. Sorry for the slight delay.
Share screen.
Okay, yes, as introduced before, I am by the names Patrick. I'm a first year resident of Science department in Mbara. And in the department, we have the committee of monthly report that we always compile as an initiative to improve on our quality, our care. So I will be giving you some of the findings in maternity care services at Mbara Regional Referral Hospital, and during and after COVID-19 lockdown. And down there are my co-authors. So as we know, during the COVID pandemic, Uganda had total lockdown as one of the measures in the fight against COVID. And this included the banning of public gatherings, suspension of public transport, and curfew, which were in two phases. In 2020 March, and then the second phase in 2021 April, and the easing of this lockdown was effected this year, 2022 January. So as you know, countrywide, the data is lacking in the impact of COVID-19 in the service delivery as per reproductive health in Uganda. So our objective for this analysis from our routine report was to compare the maternity care services at Mbara Regional Referral Hospital during and after the COVID lockdown. And we did a retrospective review of our report, our monthly report, and we also contrasted in two periods. That we picked the one for the financial year 2021 and 2022. So period A was from July 1st to December 31st, 2021. That is when the COVID-19 restrictions were still in place. And period B was, we compare January, we saw the report of January 1st to June. And then, fine. So we analyze this following, the following indicators. We first use the Excel sheet and then starter version 17. And then we did the continuous variable, summarize it with the means and then standard deviations. And then we ran it through the student test. So when we did the analysis, we had a null hypothesis that there was no effect on the maternal service delivery during the COVID lockdown and then post-COVID lockdown. And as we see from the monthly trend, though the graph is skewed to the left, yes, we shall see the summary, what our test is going to tell us. This is the trend for the antenatal care and then the postnatal care attendance. And then this is the trend in the deliveries. We have the normal deliveries and then cesarean section. The graph also saw that it is normally distributed and was not affected. And also in the perinatal outcome, okay, the adverse perinatal outcomes, yes, felt the graph also saw that there was no much different when you see from the period of July to December 2021, then January to June 2022, which comprise our groupings, yes. Then also in a referral was not markedly affected. It was also normally distributed throughout this period when there was COVID lockdown and then easing out. So when we saw those analyses, and then we were convinced that yes, there was no significant difference. We had to run it through the starter version 17, and then the major findings were that yeah, there was significant difference in the maternal monthly antenatal clinic attendance during the time when there was COVID lockdown, compared again when there was easing out of the measures. And then also when you look at the monthly postnatal visit, it's also at the borderline, showing that yes, there was some, though in the borderline, but it's there's some significant difference. But the rest of the indicators shows that there was no significant difference. So in our conclusions, yes, we found that COVID-19 lockdown did not affect so much our service delivery, and except in the antenatal care. And then also we saw that there was no significant difference in the facility maternal perinatal mortality. So I think this were basically maybe contributed by the reason for the significant rise in monthly antenatal care could be during this breakdown. Always the peripheral facility diminished in function and loading the tertiary facility. So our recommendation is that further studies are still required to elucidate maybe some impact on of this in the home deliveries. We don't know. We did not capture. We don't know the data on the home deliveries as per the factor of COVID-19. And I would like to acknowledge following our HOD, Obscine, and then the patrons of the monthly reports, and then all the specialists, and all my fellow residents, and all the midwives for this collective contribution. Thanks so much.
Thank you, Dr. Petrop, for that insight into what happened during the COVID-19 lockdown. Our next presenter is Dr. Susan Atire. She's a consultant in reproductive medicine at the Mulago Specialized Women and Neonatal Hospital. She's also a PhD fellow at Makerere University. Dr. Susan is going to share with us what she found when she tried to find out whether misoprostol given by midwives works better and more safely than that given by physicians. Let us welcome Dr. Susan.
Thank you for that kind introduction. Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Yes, we need to be more awake. Yes, so actually the study we were doing was to actually see whether if misoprostol given by midwives, our outcomes are the same or similar as when it's provided by physicians. And the genesis of this research was based on the gains that we saw in first trimester PAC, where we found that actually when midwives are involved in managing these patients, there is better access to care, and the quality of care is provided is much better. So that's the, yes, so that will be my presentation outline, and I have no conflict of interest to declare. If you look at sub-Saharan Africa, we see that 1 out of every 150 women who actually have an unsafe abortion die from this complication. And according to the NPDSR report of 2019-2020 of Uganda, showed that 80% of maternal mortalities are actually attributed to abortion complications. However, we know that mortality from abortion is largely preventable if we do these key strategies. For example, sexuality education in schools, empowering the girl child, keeping them longer in schools. If women are able to access family planning, effective contraception, for those that meet the prerequisites of having a safe abortion, if actually that is done, and then post-abortion care for those that eventually have complications. And this is the opportunity that we see where we can actually have task sharing with our midwives. We are all aware, or most of us are aware, of the 5 essential elements of post-abortion care. And if we focus on the emergency treatment element, WHO, if you look at the abortion care guidelines that were released this year by WHO, they stipulate the treatment methodologies that we can use if a woman comes in with a 2nd trimester incomplete abortion. So in there we have misoprostol, we have manual vacuum aspiration, we have dilatation and evacuation, and you can see that the last one, B and C, is actually not recommended, although that is the common practice in most of our facilities. So why look at 2nd trimester? So studies that have shown that actually women with abortion complications, if you compare those in the 1st trimester and those in the 2nd trimester, those in the 2nd trimester will most likely die from those complications. And the HMS BAB study is a study that was done by AOGU a few years back. And when we did a secondary data analysis looking at the women who had abortion complications, we actually also found the same, that those that were in the 2nd trimester had much more mortality compared to those in the 1st trimester. Go back, move back. So that was our study objective, and our hypothesis was that the effectiveness, safety, and acceptability of misoprostol treatment for women with a complete abortion, if provided by midwives, would be equivalent to that provided by physicians within a predefined equivalence margin of -5 to +5. So this was an equivalence trial. So we're not saying that the midwives are better or the doctors are better. We wanted to check whether if care provided by midwives is equal to that provided by physicians in this particular group of participants. So this trial was conducted in 14 health facilities in central Uganda, 11 districts, and these ranged from Health Center 4s up to the National Referral Hospital. And we included participants with signs and symptoms of incomplete abortion and with a uterine size that ranged between 13 to 18 weeks. We excluded women who required urgent management. So for example, if they had excessive bleeding, unstable hemodynamic status, or if they had sepsis, so those were excluded. And the dosing regimen that we used was 400 micrograms of misoprostol And this was given every 3 hours up to a maximum of 5 doses. And we assessed our main outcome at least at 24 hours, or if a lady expelled the products of conception. So we did a surgical evacuation if at 24 hours someone hadn't completed, or if during the period of treatment they had a deteriorating clinical status. And all these were inpatient, managed as inpatient. So our primary outcome was a complete abortion without a surgical evacuation within 24 hours. And yes, so the results. So this work has been published recently in the Lancet Global Health. And in the results, we saw that when we compared the social demographic characteristics, there was statistically no significant difference. So meaning that the randomization actually was done well. Let's skip that. Yes. And then among all the participants, we found that 93% of them actually had a treatment success. 92% in the midwife's arm and 94% in the physician's arm. So our success rate was actually higher than what we had previously anticipated. And the difference was -2.3. And you see that this and the confidence interval actually fall within our predefined equivalence margin, showing equivalence. So when we looked at the secondary outcomes, except for unscheduled visits, all the other secondary outcomes did not statistically differ between the two groups. And the median dosing was 1,200 micrograms, which translates to 3 doses. When we compared the time from starting misoprostol administration to actually achieving a treatment success, so the median time was about 6.1 hours, and still this did not statistically differ between the two groups, and the median duration of admission was 21 hours. Keep in mind that all these were inpatients, and we're getting our maximum. The maximum duration of treatment was 24 hours. We then looked at acceptability. And for this was a mixed methods study. So in addition to the RCT, we did some in-depth interviews for about among 28 women. And here we did maximum variation sampling. And what we found was that 94% of the women actually found the treatment satisfactory. And this did not significantly differ between the two groups. So our overall acceptability was actually a composite variable where we looked at treatment experiences and satisfaction. And if the treatment experiences were as expected or easier than expected, and the person was satisfied, we took them as having satisfactory overall acceptability. And in there, we have quotes showing that actually our healthcare providers were providing good care. There were some challenges, but despite the challenges in terms of providing essential supplies, they were explained too. When we compared the social demographic characteristics against our main outcome to try and see some of the factors that were associated with the satisfactory acceptability, we found that treatment success and a client being calm and safe were actually key determinants of satisfactory acceptability. And then as someone's bleeding got heavier or experience of side effects, that had a negative impact on satisfactory acceptability. So this was one of the participants who said that, yes, she received misoprostol tablets. Yes, she received the pain, but in comparison to previous experience with surgical evacuation, actually the pain was much, much later. Please note that these side effects are known and can be managed within our health facilities. So in conclusion, we see that misoprostol treatment of uncomplicated second trimester complete abortion is equally effective, safe, and acceptable when care is provided by midwives compared with physicians. And the treatment success and feeling calm and safe actually promote acceptability. And on the reverse, on the other hand, side effects and worrying bleeding patterns have a negative impact. So what do we recommend? The one key recommendation is that we need to improve accessibility of PAC by including midwives in second trimester management of these patients, of course, through policy guidance and programming. And secondly, from our interaction with these participants, we realized that there was a lot of misinformation and fear in regards to the kind of treatments that people get. So most of them are aware of the surgical management, and they don't know that actually there is medical management as well. So we can use multiple communication channels to sensitize key stakeholders on issues regarding prevention, how to seek care, and available treatment options. And then possibility of conducting further research on task sharing on second trimester PAC, focusing on misoprostol dosing, because our study was looking at maximum of 5 doses, and we saw that close to a quarter of our participants actually experienced side effects. And this had a negative impact on their satisfaction. The current guidelines actually removed the cap, so there is no maximum dosing. It's left to the prerogative of the attending healthcare provider. So what impact does this have on patients' acceptability? So that is something that needs to be looked at. So I'd like to end by acknowledging one, my supervisors, those 2 ladies and 2 gentlemen up there, the doctoral committee members, Professor Nachmuli, Professor Dan Kaye, and Dr. Sechkubo, the study coordinators, without whom I would not have been able to have done this study in these so many sites, the healthcare providers, some of whom are in this room that participated in the study participants, and the PAC research group. This work was funded by Thrive and the Swedish Research Council. Thank you.
Thank you very much, Dr. Susan, for that wonderful presentation. We as AOGU members work on a daily basis with the people who manufacture and even make the drugs accessible for our patients. So as we prepare our few questions on the different presentations, I am going to ask a representative from one of the stakeholders, a pharmaceutical company called Oman. His name is David Katete, to come and take us through a short presentation as we prepare a few questions. I see our time has gone, so we'll only have time for a few brief questions after this presentation.
Protocol observed. Good morning. My name is David Katate. I'm a pharmacist from AOGU Uganda Limited, the importers of the high quality Jordan products. Thank you, the organizers of this conference, for this opportunity, even us to partner. This morning, I'm going to speak briefly about the effects of urinary tract infection in the reproductive health of women. Urinary tract infections, these are infections of any part of the urinary system, that is the urethra, the bladder, and the kidneys. And the most causative agents for these urinary tract infections are the gram-negative bacteria, which account like 90 to 93%, and some gram-positive bacteria. But among the most common causative agents, among the gram-negative bacteria is E. coli, accounting 85%, followed by Klebsiella species, Proteus mirabilis, and others. Globally, 11%, the prevalence of UTIs in women is 11%, and 50 to 60% of adult women will have at least one UTI in their lifetime. This is a study which was done in Imbarara. Which was done in Imbarara. It is a cross-section study done in Imbarara Regional Referral Hospital in the month of November 2019 to February 2020, assessing prevalence and antimicrobial susceptibility of symptomatic UTIs among 400 pregnant women. But the research findings from this study found out that those symptomatic UTIs, after doing after doing urinalysis and they did culture on it, 35% tested positive. And in this same study, they found out that gram-negative bacteria accounted 73% and gram-positive bacteria accounted 23.5%. But what was shocking with this study found out that all isolates were found to be resistant to the commonly used antibiotics. Those are the penicillins. But still, this study found out that in the isolates, they have found that the isolates were susceptible to the third generation cephalosporin. In specific, that is ceftriaxone and cefotaxime. This study concluded by saying that there is high resistance to the commonly used antibiotics in UTIs. With this high resistance, doctors, if UTIs goes untreated or be poorly managed, it can negatively impact on the reproductive health of the woman, of the pregnant women, resulting into low birth weight and premature birth. Doctor, this morning, I want to present you a solution. In 1979, scientists had already made third generation cephalosporins, but during that time, they were IVs. Now scientists scratched their heads. They wanted to make third generation cephalosporins, which are broad spectrum in nature, having good gram-negative coverage and good gram-positive coverage. But still, they wanted to get that oral third generation cephalosporin, which is still more beta-lactamase stable. And they are able to make cefixime. Now, doctor, I want to introduce to you Cefix, a third generation cephalosporin. A third generation cephalosporin, and it's given orally. The mechanism of action, doctor, it is bactericidal in action, inhibiting the cell wall synthesis. And Cefix, doctor, it is highly beta-lactamase stable to the most of the beta-lactamases. There are very many beta-lactamases, but Cefix is stable to the majority of the beta-lactamases. The pharmacokinetics, doctor, for Cefix is widely distributed in a body tissues. It is not metabolized by the liver. Therefore, for your patients who have liver problems, feel free to give them Cefix. it is renally excreted. Doctor, I want to bring you to your notice that 50% of suffix is excreted unchanged in the kidneys. That means that the 50% which remains unchanged, they're going to have interactions with the probable gram-negative bacteria, which may be attached along the tract. Doctor, I know most of the time you deal with pregnant mothers, and the drug to give to your patient, it should be safe. Doctor, I want to assure you that Cefix is a Class B drug, safe in pregnant mothers, and no significant drug interaction have been reported to date. However, don't give Cefix along with warfarin. It is a common rule with all the cephalosporins. The dosage for Cefix, doctor, it is 400 milligram OD. Most times in UTIs, it's given for 5 days, but depending on your assessment, you can do otherwise. Also, Cefix can be given as a divided dose. There are some clinicians who love to give it 200 milligram BD in the adults. Once in a while, doctor, you may come across, some of your patients may have renal problems. As I say, that Cefix is renally excreted. For your patient whose renal clearance is 60 mils per minute and above, you maintain the dose. But those ones who the renal clearance is between 21 to 59, you can give 75% of the normal dose. Less than 20, half the dose. The take-home message, doctor, for Cefix, if you happen to forget everything which I've spoken about. Number one, Cefix is a high-quality Ugandan product. It has been on this Ugandan market since 2007, and in other countries, it has been in existence for 25 years. It's a broad-spectrum antibiotic having good gram-negative activity and gram-positive activity. It can be taken with or without food. As far as compliance is concerned, it can be taken once daily. It's a Class B drug, safe in pregnancy in all trimesters. Thank you.
Thank you very much, Joseph. We have a short time for questions, and we have a bit of challenge because we do not have a microphone that can move around, but we have to have the questions for the speakers to answer and have some bit of interaction. So I'll ask if you have a question, you let me know by raising your hand. Introduce yourself, ask the question briefly, directed to a speaker, please.
Thank you. I've got one question. Thank you for your very interesting presentation. Why do you think antenatal visits were higher during COVID from that? And I also have a question for the last speaker. Did it present resistance to thiamine, nitrochloride, which are very common use antibiotics, and which also at different stages of effects? If you present the results of resistance to those.
Let's first have a number of questions. The speakers are writing down and they will answer.
Yes, thank you very much. My question is
another microphone, cordless microphone.
Scientifically, which is the right dose? Thank you.
Yes, Dr. Waswa.
Thank you both. Why not hold both? Good morning, Dr. Waswa Salongo, Advanced Skilled Birth Attendant, Mbarara Regional Referral Hospital. Dr. Mubangizi, how do you think this activity you are taking on will improve male involvement in reproductive health, especially family planning? Dr. Twop, there was a lockdown, but we see the numbers are the same before lockdown and after, during lockdown and after lockdown. Why is this so? The first speaker, you said something about having had several deliveries predisposing to depression. Why is this so? Somebody has delivered, has delivered several times and is with a partner. Why then does this mother get depression? Thank you very much.
Thank you so much, all the presenters. I'm called Godfrey Siru. I'm a obstetrician and gynecologist. I just have a question to the first presenter, Henry. You, in your slides, I was a bit confused, especially when you came to protective factors. And you were comparing being a housewife was being protective compared to formal employment. I thought maybe being a housewife would be compared to being non-housewife, then formal employment to self-employment. I don't know whether it was a mix-up in the slides. Maybe you can clarify that. And then you, in your recommendations, you mentioned something about the boys, and my understanding is that maybe your study focused mainly on adolescent girls and young women. So I was interested to know that what questions did you ask these girls that enabled you to come up with that recommendation on the boys? And I think my final question was to Vincent, and very excellent observation. But I also realized that your study is actually funded, I think, by Southampton University. And no wonder you had those excellent results. So I'm wondering, and in your last slide, you are saying that you are mobilizing resources. So just, I think, like Dr. Waswa Salongo said, I'm looking at the sustainability. Without resources, do you think we can really implement that intervention in the country? Thank you.
Yes, thank you. Let's have that microphone for the speakers too. Dr. Susan, you have two questions from the chair. Which cadre of physicians did you have in the study, and which facilities did you consider, which regions were they? So, yeah, those are just questions from the chair. So now we have the microphone go around as the speaker answer the questions that have been asked.
Yes, thank you so much for the questions. I am Dr. Etwop. I have forgotten the name, but I'm answering the question as to why ANC attendance was high during the COVID as compared to when the lockdown was eased out. In our conclusion, we thought this could be the fact that Mbarara Regional Referral was the only facility providing COVID treatment in the Western region. More of the clients would come for the care And then also, in addition to that, during the lockdown, most of this lower facility sometimes diminished their functionality, and then you would find maybe they would abandon patients, and then patients would prefer coming to the regional referral for the services. Sorry, I didn't get the second question very well, but the one for Dr. Washua, why there was the same number during both, there was no significant difference in other indicators during both lockdown and when there was no lockdown. In our thought, we thought that yes, this could have been due to the uptake of reproductive care package by the community due to the sensitization, probably. So those who have been attending the antenatal care before and had understood what the health workers were telling them, though yes, in the indicators I made mention, I did not capture the data for the high risk, but in our crude data, the high risk cases were also high. That contributed to the increase in the antenatal care package. And that is why we say more study would need to follow up these post-COVID mothers, probably, on any complications that could arise due to COVID infections. Thank you.
Thank you, Chair, for those questions. The cadres of physicians varied from medical officers to residents to obstetricians and gynecologists, and the duration of working in employment ranged from 1 year up to 30 years. So there was a wide variety of spectrum in terms of the doctors that were participating in the study. The study was done in the Central Region, and why? Because at that time, the proportion of women who had induced abortions was actually greater in the Central Region compared to the national average. So that was 56 versus 32 per 1,000 women within reproductive age. Why was this important? Because we needed to conduct the study in an area that had, that we thought would have a high disease burden. And of note is that we were able to get our sample of 1,191 women over a period of 3 years. Yes, so it took quite a bit of time. So that's why we chose the Central Region. Thank you.
Thank you. I'm going to start by answering the question which was one of the doctors inquired about 200 milligram BD dosing versus 400 milligram OD dosing. When you try to search on net, on studies which have done, trying to compare cefixime 200 milligram BD to cefixime 400 milligram OD, they conclude and say that there is no clinically significant difference. But there is a certain SHO gynecologist, an SHO who is doing OBS and GYN. This is what he told me. He told me that there was a study which was done in Ginger. This one, I didn't read the study, but I'm trying to quote what he said. He said that since urinary tract infections, the pathogens are in the urethra and the bladder. When you give 400 milligram OD, as I said in the pharmacokinetics, that 50% of cephix, which is in saturation, is renally excreted unchanged. It means that if you are treating, for example, maybe a cystitis or a reflux, when you give a 400 milligram dose, it means that there's going to be a symptom relief is going to be very fast when you give 400 milligram OD. But there are some infections which are systemic, which are which not only be in the urinary tract system, but they go throughout the whole body. Now, a 200 milligram dosing will be better in that situation. Thank you. Maybe another question which was asked about the resistance pattern on nitrofurantoin. Among some of the studies which I came across, they show that nitrofurantoin is most, like in that study which I presented, nitrofurantoin wasn't resistant. Those microorganisms wasn't resistant to nitrofurantoin, but I know most times when you look at the safety profile of nitrofurantoin compared to cephix, you may recommend cephix. Thank you very much.
Yeah, I think it's better I respond standing. Thank you very much for the questions. Now, our study being a complex study, we may not be a complex intervention, we may not be able to tell exactly which part of the components worked to improve male involvement. But our findings point out the following, that actually couple counseling at home made males get involved. Our VHTs would go at home, maybe the first time they don't find a man, they talk with the woman, then they make an appointment with the man. And when they would talk with the man, some of the men would say, I didn't think that, I had not known that I had needed to be involved in the pregnancy or in family planning. I thought it was an issue of the woman. Two, we found that even when you go to health center, sometimes I've been telling people, you go with your men, women should come with the men, but the question has always been, when they come together as a couple, do actually men get involved, or they feel their job was to give maybe transport and they are neglected? So being involved, feeling that they were a welcome party to the health facility, encourage them to get more involved. Three, we're also showing the films, and they learned also from those educational films, both at home, because the VHTs show them on a smartphone, and also when they come to the health center, they would learn from those films, so encourage them. And also, last but not least, the availability of those services at awkward, what we call like awkward time, also was an attractive thing for men. You know, when we tell men to go to health facility, sometimes they say, you know, when the women are going to health facility, me, I'm working to look for the money to feed them and so on. And they are always busy. But when we tell them to come to health facility at their convenient time, it also makes them get involved. And also found that men listen more to VHTs and health workers than their wives. So involving the VHTs to do more visits may make the man pick interest. And then the last question was about the sustainability. That's a very big, difficult question to answer, But remember, our study is a pilot feasibility study. And when we finish a pilot, once these funds we form this small catchment area, can it also apply to other big area? And then from there, we can make the recommendations of sustainability. Thank you very much.
Thank you so much for Chair. I want to respond to the questions that were raised. One was inquiring about why more than three or more pregnancies among adolescent girls and young women was significantly associated, was found to be significantly associated with depression symptoms. One of the explanations to this was that we were, first of all, we compared this with those pregnant adolescent girls and young women who were carrying their first time pregnancy, the prime gravidas. So the explanation to this was, of course, we know that adolescence is a period of transition. And we also know that pregnancy among this age group carries many psychosocial issues. And I think in addition to the physical stress that pregnancy puts onto these young women, so we realize that every subsequent pregnancy sort of predisposes them to more to depression symptoms. The other question was that housewives, being a housewife for these pregnant adolescent girls and young women was found to be protective. We were comparing this to those who were in formal employment. So in our inquiry, we were asking them about their occupation, but we found that many of them actually were reporting as their occupation being housewives, like they are at home, they are stay-home mothers. So this was found to be significant, and it was protective. And the explanation was that the adolescent young girls and the adolescent girls and young women were they found being, I think, in these relationships where they're housewives as some kind of giving them some comfort. This comfort, in this study still, to us it was sort of short-lived. That's why one of the recommendations was like, we need to skill them. We need to give them skills during, whether in school or out of school, so that at any point in their life cycle, they can always have that as their fallback position, rather than thinking that being a housewife is the better option or is more sustainable. The other question was asking about why in the recommendation do we mention adolescent boys and young women. In one of some of our significant factors, we found that lack of low partner support was among, and then intimate partner violence. So we think that, and we've always been mentioning about male involvement in SRH issues. So we think that we need now to sort of trim down our information, our messages, and give age-appropriate messages to the adolescent boys as well. So we think when we use such broader strategies, we can sort of reduce and involve these young boys, the young men. It can help to bring them on board and then support the girls for those who really become pregnant. Thank you.
Thank you very much. Let's clap for our presenters again. Dr. Patrick, Dr. Susan Akire, Mr. David Tete, Dr. Vincent Mubanjeze, and Dr. Henry Cheza. Thank you very much for these presentations and for answering the questions. We've come to the end of the session. Those who came in late, Dr. Rogers Kajawangu from Barara University, who has chaired this session. Thank you very much and have a wonderful day going forward.
Thank you very much, Dr. Kajawangu. Thank you very much, Dr. Kajawangu. On the program, we are going to have a slight change because we are still waiting for the official guest of honor to open the conference. I would like to call up, we are going to have a change and have the session that was going to follow the opening ceremony, which is the panel discussion. I would like to call upon Dr. Kazikwe, who's going to come forward and moderate this panel discussion on the role of subspecialties in obstetrics and gynecology. So Dr. Kazikwe, you are most welcome to moderate this session. After the session, we'll have the break tea, and I hope by that time the guest of honor will have arrived and have the official opening ceremony. Thank you very much.
Thank you very much, Prof. Kaye, for the introductions once again. Good morning, members, those of us that have just joined us. You're most welcome to this conference, scientific conference, where we're sharing to improve towards this theme that was well chosen by the conference committee, securing the reproductive health future for the women in Uganda. The discussions about leadership and governance, implementation of regulations of subspecialties in obstetric practice. Dear delegates, allow me to invite, with the adjustments from what you see the program, the panelists. Let me welcome Dr. Nabunya Every to join us at the front. Dr. Waswa Salongo, please join us at the front. Dr. Musa Notieno, the president of AOGU. Dr. Olive Sentumbwe, please join us at the front. And Dr. Christine Biawarema.
Thank you so much, panelists, for accepting such a short notice to be part of this discussion. We will discuss leadership in subspecialties. Dear members, you've seen that most of us are, especially in public institutions, are improving our academic potential. Going for PhDs, fellowships in the different subspecialties, infertility, endoscopic, colonoscopics, we have for urogynecology, maternal specialists. What's the role of these different institutions? For example, the ministry, what program is it there to really cater for these subspecialty persons needed in the system? So the people have introduced, please feel free when I hand over the microphone to probably add a little biography in relationship to the session, which is on leadership and governance, as you answer the session.
questions that will be posed to you. Let me begin with my immediate the president of the association, Dr. Musaba. What is the role of the professional associations in leadership governance and ensuring that we are implementing subspecialties and also reflecting the theme, securing the reproductive future of our women in Uganda?
Thank you. Using it smile most of the time. I'm a super specialist myself. I'm a gynecologist who benefited from the government program. However, as you know, I saw in the private sector, means there's no one from in the public sector at the moment. Now, what about the role of the association of gynecologists in super specialization? AOGU has priorities, an agenda that we are pushing as an association. One of them is to increase access to and extend existing ONG services, including super specializations. That is the width of coverage and access. And over the years, we know that many of our colleagues are now super specializing oncology, MFM, and the rest. The second one is advocacy. So in terms of increasing access to services, one of the things we are advocating for is a change in the structure at the General Referral Hospital. Generally, most of our hospitals just say we want obstetricians and gynecologists. But I think that time has now passed because the capacity is now there. So we are pushing for the General Referral hospitals to have specializations. General obstetrics, urogyn, MFM, gynecology, and whichever else is there. Then, of course, now over the years, I think government has invested in a superstructure, which is the specialized women's and newborn hospital, where I think that their role is to offer leadership to the rest of us on how we can develop and manage these super specializations at the regional level, but also in the private sector, because you still take lead. So, as an association, our role is to advocate, sometimes put some pressure on people to make sure that they deliver on an agenda. So AOGU's role is to, one, push policy at the ministry, push policy at with members, push policy at General Referral Hospitals. And this year, I think we've visited most of you to try and push that agenda, whereby we don't employ people only as ONGs, but as super specializations. Thank you.
Thank you so much, my president, for the response and the role that you're playing in terms of advocacy. Members will be joined by two more panelists, Dr. Katumba Gubalimosokam and Dr. Sechukuba Musa. You're highly welcome. I'll continue with the other panelists, Dr. Waso Salom. You've really trained almost half of the team in this room. Where do you see leadership governance in reference to leadership governance? Where do you see your role in advocating, trainings, to ensure that we should implement the subspecialties in the system, health system in the country? You're most welcome.
Thank you very much, Dr. Kazberore, Dr. Waswa Salongo. I like to be referred to as an advanced skilled birth attendant. I'm here to become a super specialist, but I am pushing the younger people to do these super specialties. And when they come back, they say, Dr. Waswa, look at what I've done. And it feels great. My teachers, it feels great. Our president mentioned the issue of the association. I think it is true. These super specialties are coming out, but they seem to be unregulated. Everybody does his own thing, his own way. Now, the association needs to now draw the line. Who should do what? Where should it be done? Okay, there should be a guideline of what is done. Supposing we get litigation, how are we going to manage this? There must be some guidelines, and then the association with the knowledge and the experience should be the guiding parent behind that. And of course, the Uganda Medical and Dental Practitioner Council will have the oversight, will still maintain that oversight activity. These super specialties are forming subgroups, associations of their own. And these too must be regulated. And they need the advocacy of the senior persons who have been there. Okay. Dr. Now is going to become a past president. What is his role? His role would be to advocate. How do we regulate these things? What have you seen? You've traveled out here, out there. What have you seen? How have they regulated that? And that is one of the things that the senior persons should be able to do. Not only say, I know. Let the young people come out and show you, and then you say, I think you need to move a bit this way. When you say Dr. Waswa, people will say, oh, I've heard about that one. What can I do to let people know that these specialties are around? Talk about them. Let people know that you don't have to go to India to have an in vitro fertilization. It can be done in Uganda. And then, of course, can we have them spread out? We're having some in Barara now. But what about other regions? Can Dr. also go to those regions, talk to the persons there, and see if they can set up these issues? The president talked about regulation. Are we allowed to, as regional referral hospital, do in vitro fertilization? The regulations say no. It is the role of the senior persons to start advocating to have the regional referral hospitals, the general hospitals, to have these activities done. After all, we are saying we need an obstetrician, we need a specialist at the general hospital. Is he going to just take out the uterus? And are there no mothers who need, ladies who need these super services? It is time for us to advocate for even these services to go down to these lower units. We want to thank our Secretary of the Uganda Medical and Dental Practitioner Council. We have specialists at general hospitals. It took time. It should not take the same amount of time. And then, of course, these super specialties are going to need equipment. Let's not just have anybody ordering any equipment from India, from America. Let's have something specific, something standard, something which we know will work. And of course, these equipment are rare, they are expensive, and they are delicate. You're not just going to go and put them out there. I know my urogynecologist, my urologist in my hospital takes care of his equipment himself, specifically because there's need for user training. Has this been done? Are we doing user training with all the other hospital equipment? We need to look into that. And then, of course, there will be need for planning, where to acquire them from, need for maintenance and after-sales services. These are important things. And who other than the senior persons to say, I have seen this being done. And then, of course, the issue of training. Who should be a super specialist? I'm sure somebody will talk about the issue of the curriculum, where to do the training. Is it enough to be attached to somebody who's doing IVF in vitro fertilization to become a specialist in that line? Then, of course, Mr. Chair, is the issue of remuneration. The commonest thing that we are seeing is the anesthesiologists and anesthetic officers. They have a diploma in a subject, and then they do another diploma, but they remain on the same standard. If somebody has gone out on initiative and comes back as a super specialist, should he still be getting the same salary as somebody who stayed around, has put in an effort, is better qualified. We need the Health Service Commission to come in, the Ministry of Health, the Uganda Medical and Dental Practitioners Council, and then of course, the Ministry of Finance. They have to plan for these issues. Training as a super specialist is not easy. Somebody will talk about the curriculum. Who should we train? What should we train in? Where should the training be? Can't we have this training here? Of course, ladies and gentlemen, if we have these super specialties in Uganda, why would you have to spend so much going to America, to India for these specialties? The senior persons around, those of you who have been there, it is time to start advocating for these super specialties, getting down to the lead persons, lower health units, start offering these. At least do the initials and then refer appropriately. Mr. Chair, that's what is super specialties in Uganda.
Thank you so much, Dr. Waso Salongo, for elaborating on the facts that you've seen or experienced. You've really talked about unregulated services. Dear delegates, when we talk about specialization, we're not talking about only the gynecologists or the medical officers who are training in given subspecialties. We, the nurses and midwives too, have made the investments, sometimes personal investments, to better our professionalism. And what happens when you come out of these trainings? You would want to recover your funds. Not so. And that way, we tend to set up our own institutions and start what we look at as exorbitant costs, and basically working as if you're not regulated. Dr. Katumba Sentongo, what is the role of Uganda Medical Dental Practitioners Council in terms of regulating, first of all, the trainings, and then the products that come out of these super specialized services in the country?
Thank you, one moderator, seniors present here, colleagues. I'm happy to be here again and give you an insight of what the Medical and Dental Council thinks about the specialists and your profession at large. I want to immediately say that the council is already working with the AOGU. The president submitted a draft MOU, which has been processed by council with some amendments, and it is going to touch most of the areas we are talking about. I'm very sure you must have seen the draft, but some of you, if you didn't, it will be saturated again so that you are aware of what your association wants to do with the council. Some of the things that we are interested in, first of all, the government, the specialist register, the council doesn't have a specialist register, and the council has submitted to the ministry to establish that register so that people study and they are recognized and enumerated as such. But at the moment, there's been a problem, people study and it just stops there. Then secondly, we are aware, and you are aware, of the new trainings which are taking place. You are familiar with the MMed program, but now there are extra programs of the fellowships. I want to inform you that council made a guideline, a regulation, which you are aware. Some of you, if you don't have it, we can saturate again, which allows council now, the Medical and Dental Council, to accredit the fellowships under EXA and any other training institutions like Heart Institute and UCI. This was passed, and we have since accredited training sites for fellowships for surgeons, physicians, anesthesia is coming on board, but we also done Heart Institute and Uganda Cancer Institute. And I want to tell you in that vein, Council is going to have an academy to regulate all of those because different type of training. Though all trainings are related to the major organization of EXA, which is 14 countries, but you see the fellowship trainings, they're much more serious, I want to say more than MMed, because MMed is having a, and if teacher X is missing, another one can really fit in. But for fellowship, you are really attached to a person and it should be known that he's there. If he leaves, it means that site has to be closed. So we are going to have an academy which will manage all these fellowships, whether it's surgery, obs and gyn, medicine, and whatever, so that we are hands-on. We can easily go to Mbarara if Dr. Wasa is not there and have that site closed because we don't want people to waste their time. You do those university exams with other countries, but the student can waste his time if the trainer is not there, and that is not good, it's not professional. Now, the MOU which we have talked about, we are looking at giving AOGU more powers on self-regulation. In other countries, the medical councils, actually, they handle what they call weight cases. Those very serious, very dangerous cases of high unprofessional conduct, okay? Like that gynecologist in UK who was using IVF to make everybody pregnant with his sperm. You heard about that one. But these simple ones of obs and gyn practitioners somewhere are directing a Caesar which is not indicated. That can be handled by the association because we know these people and you don't need to wait for counsel. Because sometimes I hear counsel has not done this on this doctor. You are the ones who know what he's doing bad. And I really don't see a senior Dr. Viriavalema or Dr. Semtungwe knowing a young colleague not doing the right thing, not doing that. So we want under our MOU, which we want to give power for this association to be working on such things. We're talking about CPD. Yes, really, if you are obs and gyn person working in the country, you're working in the country, you should appear in conferences like this. We need 48 credits to renew our licenses, but we really want over 70 under a professional association like this. Because even if Dr. Navinya, my former, we started together in Dar es Salaam, even if she's in administration, I don't expect her CPD to come with procurement credits and whatever only at 60%. So we want to go in that. Now, regarding standards for all, including specialization by a moderator, we really want the association to be the forefront of setting standards to do with the curriculums. Because these specializations are coming, but as you know, council doesn't have specialists of its own. We depend on you specialists and an organized association like yours. You can give a guidance on what should be in a fellowship program running here in Uganda, what should be in MMed if it is being changed with the new changes which are coming up, the new specialization like IVF and whatever urology, what should really be there? But it goes down now to MBCHB program, and also now this Bachelor of Midwifery, but there's been a problem there on who is going to supervise those people for internship. So those are regulatory issues which we really want the association to participate in. I want to end at this side, talking to the seniors directly. We at the council expect a lot of guidance of the seniors, the junior colleagues. The seniors are very few. There are many universities now producing people. So there's a need for mentoring and real guidance. Council has noted that sometimes some seniors have not done the right things to the detriment of the profession. I say, hey, is this by a senior? So we expect the seniors to do the mentoring and the guidance to the much more many colleagues which are, who are down, so that the self-regulation starts with us. I thank you at the moment.
Thank you so much, Registrar Dr. Katumba Sentongo, for the submission. We are seeing you, Dr. Christine Biarema, as a very senior trainer, but we are also seeing in the lenses of being entrusted by the Minister of Health, amongst your titles or roles, being a board chairperson of Kawempe National Hospital. Is this super specialization important? How do you advise accounting officers to plan and actually recommend their staff to go and upgrade into this super specialization? And two, once they are done with trainings, how do we retain them? Otherwise, like you've had out there, super specialization is a virgin area, and most of us want to make a kill out of this super specialization. So how do you advise the accounting officers to really encourage staff members to train and super specialize? Remember the theme, we need to secure the reproductive rights, health rights for the future of the women in the country. And two, advise on retaining them. Thank you.
Okay, thank you, Dr. Kazwe, for that. My name's Christine Bidiavalema. I imagine most of you don't know me because I'm a retired general, but I'm still practicing. And somewhere you may meet me. Now, before I go to Dr. Kazwe's question, I see two issues. There is specialization and super specialization. And I think we need to define those, because there are some specializations that should be there without any debate. And to come to my colleague, Dr. Musana, I think we should all have an oncologist in all these hospitals as a specialty. And then maybe if we are going into the molecular oncology, then we move into super specialization. That's my thinking. If you have reproductive health as a specialty, then you see which angle to take off in super specialization. I think we will need guidance at the end of the day, maybe from the council or from the trainers whom we have, as to what we call a specialization that should be normally integrated into our services, and a super specialization that can be reserved in some areas. Now, as chair of the board of Kawempe Management Referral Hospital, I get confused with their title. Now, the role of the board is to give strategic direction within the framework of the health policy. I don't know how many of us have looked at the health policy, but it spells out what should be within our services. And then another role is to review the annual work plans, budgets, and provide oversight to management, and also to management of human resource and mobilize resources as part and parcel of the role of the management board. For me, I believe that all these regional referrals, national referral hospitals should have super specialization services offered to the community. And as as a board, one of our mandates is to encourage these hospitals to give services to the community. So if you super specialize or you specialize and someone needs like a heart service, in OBGYN, I don't know if they need IVF, should they travel to Kampala or they should go to Mbarara or to Kabale or to Fort Portal and get the service there? Should they fly out of the country when we can have these services here? So if the hospitals can justify their budgets and the human resource, and they can convince public service to approve those budgets, I would have no objection to convince the board to approve that super specialization. So the accounting officers need to look at their human resource. They don't have to live in a box. They can justify, and if one of our problems as health workers is that we are not good politicians, we can't talk for the budgets. If we can speak for that budget which you have put forward, justify why you need a super specialization in your hospital, it will be approved. Thank you.
Thank you so much, Dr. Riyabaleba Christine, for the wonderful submission. I hope delegates, you're taking note of what we are submitting and ensuring that we pick a leaf in terms of taking messages back home and implementing these to ensure that we have a secure future for the women in Uganda. Dr. Nabunya Evelyn, you are the Executive Director of Mulago Specialized Women and Neonatal Hospital. You are indeed implementing subspecialties in that hospital. Can you kindly share your experience with the delegates? What has it taken for you to implement the subspecialties in the institution? What challenges are you facing and how are you overcoming parts of recruiting, spreading out scope of work, the equipment you require, and incentives or motivating these specialists to work out of the usual remuneration coming out as either consultants, senior consultants?
Thank you very much, Dr. Kazibwe. I'm Evelyn Nabunya, OBGYN, and ED of Mulago Specialized Women and Neonatal Hospital. I wish to take this opportunity to thank the organizing team for this conference and for organizing such a discussion. I'm privileged to be part of the panelists together with my fellow panelists. At this time, as you've heard, this is Mulago Specialized Women and Neonatal Hospital, the first super specialized hospital in reproductive health care in Uganda and probably in the region. So we are grateful to the government of Uganda for setting up such an institution. I'm grateful to our teachers who are present here with us. Dr. Birama is here and all the other teachers and members. And I'm grateful to the members of Mulago Specialized Women and Neonatal Hospital who are the first staff to serve in such a hospital. Can we recognize them? Can they stand up, please? Mulago Specialized Women and Neonatal Hospital. Women's Hospital. Women's Hospital. Indeed, in the best hands. In the best hands. Thank you. So I just want to start with a brief history because people may imagine that super specialization started with Women's Hospital. In 2008, while we were in Mulago National Referral Hospital, the concept of subspecialization came in. So that's when the department, which now had become a directorate, broke up into subspecialties. And we began with 5 subspecialties. And at that time, Dr. Barima, you were there. We had urogynecology, gyne-oncology, general gynecology. At that time, we had maternal fetal medicine and reproductive health or reproductive medicine. There were 5. So we began, but with no super specialists, right? But people had an interest in those areas with the hope that each one would be able to grow in that area. And indeed, growth has happened, and we've seen growth in each of those subspecialties. And a number of people, although few, have been trained. For example, if you look at reproductive medicine, we do have an endocrinologist, our teacher, Dr. Businje, and because of the initiatives there, we now have a menopause clinic, the first in Uganda, in a public hospital. It is functional and it is there and it's led by him. We do have an embryologist, the first in a public hospital. We have Dr. Kaira, and we are starting our first sessions of IUI and very soon IVF. So you can see one subspecialty growing into others. We have minimal access surgery. We have a team offering that minimal access surgery, laparoscopy. A number of procedures have been done through those teams. We have members like Dr. Mwanje, Dr. Rujumba, Dr. Mugisa, they are all working together as a team. We have a team offering that. So you can see that each of those subspecialties is growing further. It has not just stopped at general, but going further into specialization. But for us to grow into super specialization in OBS-GYN or reproductive health, we cannot work alone. We need other areas working together with us. For example, in radiology, there is also super specialization there, interventional radiology. We need high-level radiology to support our super specialized services in reproductive health. We have anesthesia. We need super specialists in obstetric analgesia and anesthesia to also help in our specialization, super specialization. In the lab, hematology and blood transfusion, among others. Neonatology, we can see the reproductive medicine, people coming up with innovations. We are seeing maternal fetal medicine with a high-risk obstetric clinic already in place. So babies are now, mothers are surviving even with severe preeclampsia. We are seeing our little babies. Recently, we had a baby of 570 grams in the NICU. So we need super specialists in that is neonatology. But we also need the nursing team to match together with the specialists. So really, this needs to go hand in hand. So really, human resource planning is very important in our 5-year strategic plan. The plan was to train at least 10 super specialists per year for the next 5 years to be able to get a big cohort. However, there are constraints as far as the budget is concerned. So really, super specialization is very relevant, even considering the theme of securing the future in reproductive health. With super specialization, there's advancement in knowledge and critical skills. As you've heard, they are critical skills. 10 years ago, we are not doing laparoscopy, but now we are doing. We did not have IVF, but it's about to start, and many other areas. It prepares the health specialists, students in this super specialization to be able to offer these services. So giving competent sub-specialists in these areas. There's also introduction of new initiatives and skills, as I've said, and this has an impact on practice. The impact is seen. the improvement in health workforce, the workforce that is there, you know, fellowships, for example, are hands-on. There's a lot of work, as was told. And therefore improving service delivery. So when we have these services available, then people do not need to move abroad to be able to have these services. But also better still, if we have these subspecialties in the different regions, then people do not need to move all the way from Gulu to come and have a procedure when it could be done in that region. So we see subspecialties really going out into the regions. And that's where we'll be able to secure the reproductive health future of women in Uganda. So there are many opportunities that we have, but the biggest opportunity is the gap that we have. The gap in training, the gap in having super specialists. So we can utilize that gap to see that we advocate for growth. We do not have many super specialists in reproductive health, but that is an opportunity to really advocate in the different groups so that we can have more. We can also have collaborations with other training sites because most of these are offered abroad, we do not have, but when we train a big cohort, then we'll be able to have these trainings within our country and not have to spend too much taking people abroad. We can start our own training sites within the country. The government of Uganda has supported super specialized training. I know the budget is still minimal, but it is there. Through the Women's Hospital, through Ministry of Health, there are people who have benefited. And we believe that there is really value addition when we have these super specialized trainings that go on. We know that as OBGYN, the department has fragmented, but this has not reduced the care for patients. Instead, it has really improved care. We've seen, for example, in MFM, we now have a fellow in our hospital, our colleague from Makerere, Dr. Kagawa, and we have set up a high-risk obstetric clinic, and a lot is being done to really look after these babies in utero together with a neonatologist. So there's planning, there's a lot of work being done. So we can see value addition in that area. We also see what endocrinology has done, the menopause clinic. Many people did not know where to go. And many people didn't know that such a clinic would happen, but it is there. And a lot more is coming. We can see the embryologists, and the innovations that are coming in together with the whole team. Laparoscopy and the minimal access surgery that has happened. We've had cases that are quite complex, not only in these areas. We've seen in gynecology, we are able to do reovertems, hysterectomies, and many more. We've seen in urogynecology, people innovating from scratch and really rehabilitating people. So there's a lot of value addition that we are seeing. So as far as recruitment is concerned, I'm glad to let you know that the structure of Women's Hospital has really catered for super specialization. So really that is important. So I think that is a step. And as structures are not static, they grow with time. So I believe even in the regional referrals, with time, we'll be able to accommodate super specialization and super specialists. Remuneration is still with Ministry of Public Service, Ministry of Health, and Finance, because they are still in the normal structure. So I'm looking forward to that, but I believe that there's a lot of hope and really a future for super specialization. So the theme for today's or this 17th conference is really in line with what the Women's Hospital is doing. And I believe that there's a lot that we can do. As far as training, maybe just to let you know that we do have a limited budget. although we'd like to take at least 10 people for training, the current budget can only accommodate 1 or 2. So there's a procedure for that. The adverts are put in the papers and applications do come in. So applications for a number of super specialized areas as far as obstetrics and gynecology are concerned. In the recent advert, however, we did not get anyone in MFM, which was a surprise. But I believe with time, we'll be able to get more and more, and as we advocate for more funds. So after opening up these in the papers, people put in their application, there's a clear spelled out procedure that is indicated in the papers. And we do have a training committee that is independent of the accounting officer that really follows this guideline so that they handle. So we are advocating for more funds so that we can be able to support more people. We know that when we train, we are training for the country, because super specialists won't be only in women's hospital, but as we said, we need to bring these services closer to where the people are. So I wish to thank you once again, and I hope we can all really speak in one voice to advocate for more training, which will improve service delivery in Uganda. Thank you very much.
Thank you so much, Dr. Nabunya Evelyn. There is job just satisfaction. We are averting medical tourism to improve on our GDP probably in the country, and all the messages that you put across. Dr. Olive Sentumbwe, you are one of our teachers. You're also wearing the other lenses of working with health partners, collaborating with Ministry of Health. Do we see your role in subspecialization? Are there opportunities in probably your sector within or without the country, within the country or internationally? And what is your message to the delegates?
Thank you, Chair. I think for us as the World Health Organization, it's important to view it from that perspective, that as a mandated global health body, we have the responsibility to promote health for everybody, men and women. I understand, and that we are also responsible to ensure universal health care and therefore access to health care for everybody. And that health care should be affordable. And it shouldn't cause really harm and risk to these individuals. We also recognize that the needs of individuals are varied, and there are very many. And therefore, we do believe that our responsibility is to support all agencies, organizations, communities, governments, to ensure that the health care that is needed for each individual is actually available within our principles of universal health care. So subspecialty is indeed fulfilling the need to ensure that the people with different needs can access that care they need. You realize that the vulnerabilities are so huge. And when you look out for those people who actually need the subspecializations and special services, they belong to all categories of people. Nobody chooses what condition they'll have. And therefore, we really work with the different research institutions, professional bodies, partners who can provide resources to the World Health Organization to ensure that research around the world that is necessary to provide the information that is needed so that we can put the necessary guidance to be available to countries to use are available. Because what the World Health Organization does is to gather the findings from these different bodies and use the various recommendations made to develop guidelines, standards, and policies that support implementation of programs in countries. So we really can't do without important professional bodies, scientific bodies, universities, and all those who provide resources to enable the necessary technologies in countries to progress. Where there is advancement in specialties and subspecialties, we know that they also depend a lot on the available technologies. We know that technology is advancing every day. And one of our responsibilities as WHO is to promote advancements being made in various technologies. And you can see that as you continue to subspecialize and provide services, you need to move with harvesting these technologies into the country. So we have a responsibility, therefore, to broker relationships with institutions and different companies that are responsible for technologies to be advanced in the world. There's a lot of innovation now going on. And also the Ugandan population, if we now come back to our country, have rights. This particular conference is about securing the reproductive health future of women. And I think in there, I hear the chairperson saying the word rights. So people have a right really to receive and have healthcare which is based on the most advanced technologies based on the affordability of the governments where they are. So we work a lot with governments and we make sure that the governments have the right policies in place, that governments secure the necessary financing that is required to push the health systems building blocks. Because if we don't have health systems of countries with the necessary health systems building blocks, it is difficult to advance with the special services, subspecialties, which you would want to progress with. So we work a lot in relation to systems and the health systems building blocks. We advocate a lot for a motivated human resource force like you are here. Because without them being there and motivated at different levels, right from their training up to when they are working, it is difficult to interest them into advancing into specialties. So we promote a lot of work to do with ensuring that the necessary available human resource is available in the right numbers and in the right training and therefore skilling. WHO also encourages that, in fact, we are mandated to work with the professional bodies like this one, to be the ones advancing the new guidance that is available. It's like, it's a given. And in most countries now, most of the guidelines that are available, new guidelines from WHO in reproductive health, we expect that they will be implemented by professional bodies and universities that are in countries. And so we also sometimes provide some limited resources to encourage research and piloting and testing of guidelines to ensure that they're properly adapted in countries. We do a lot of brokering for partnerships because as WHO, we do not have our own resources. We are funded by other organizations, philanthropists who have resources to fund our work. But our work is necessary to ensure that healthcare is based on evidence-based guidelines that are available and are newest. That is why you see us working a lot with you and the government to ensure that every so often, when new guidance becomes available, it should be adapted without us falling back to the old guidance. And therefore, for us, in relation to the subspecialties and leadership where you are, it is important to acknowledge that we really support the work of being leaders. I think we should be leaders and promote leadership and governance in this area by ensuring that you are encouraging the upcoming human resource, the young people, to really be able to be interested in the growth and development and subspecialty. So we have a role as the senior colleagues to ensure that the young people are coming up, they are being taught, and they are being taught in an environment that is conducive. Because if we do not do that, it will be difficult to see advancement in specialization and subspecialization. Some people will follow along the way and go and do other things which may not be the best where they would have wanted to fit. If as trainers, as teachers, as lecturers, you don't do that specific harvesting of the young personnel to begin to see where the future and where the advancements are, and therefore where they should be going. We thank you as trainers who have been frontlining this, but we also encourage you to work more on the development of more infrastructures, more opportunities, and to look for more resources to support you to do this work. I think that is what I have. I'm very glad to have been part and parcel of the infant and toddler steps of the Mulago Women's Specialized Hospital. And never forget to work with politicians, because I think they played a huge role, the 8th and 7th Parliament, to ensure that resources became available for that structure to be available. Thank you very much.
Can we members add a hand clap to these submissions? Thank you so much. Dr. Sechikubo Musa, you're most welcome. You are the current chair of obstetrics gynecology, Makerere College of Sciences. As you've heard from several of the panelists, we are yearning to have these young people trained into becoming super specialists or specialists. What is your role in terms of achieving this?
Good morning, everyone. I thank my teachers. Dr. Wasa taught me how to do the first vagina examination when I was an undergraduate. Dr. Christine That one will talk in private. But what you did for me at master's training was great. Dr. Evelyn Navunya, my first job posting was with Dr. Yves Sentumbwe in WHO when we were working on the guidelines on sexual and gender-based violence. For Dr. Katumba, we met during the community obstetrics and gynecology in Kalisizo, and he was such a nice host. In 2008, I had just joined the department a year earlier, and I was at the forefront of going into subspecialization. Just like any new idea, everyone was like, what's wrong with this young man? He has just come back and is telling us to go into subspecialties. But the idea was not mine, definitely. It was for the head of department. I did some reading around it, apportioning space, moving specialists who were senior to me, who had just taught me a year earlier. And it's nice that it is now becoming a hot topic in obstetric practice in the country. I think there are certain things which we need to remember as we go along, that you do not just claim a title, but you actually have the skills that go along with that title. It's not debatable. The people who have the skills in the subspecialties actually have done a tremendous work in improving maternal or women's health outcomes. Because I can relate that when we were training as postgraduate students, it was not uncommon to find a patient with VVF stay on the ward for 6 months, 1 year, repaired it twice, and all the attempts were not successful. Today, Baragaina and team repaired the fistulas of 50 women and none of them leaks postoperatively. That is positive. And over the years, what I've seen is we now need to have a structured approach to the training in the subspecialties. And that structured approach is not going to be done only by the universities, and it won't be done only by the hospitals. It has to be a collaborative effort between the universities and the hospitals. And then we also have to bear this in mind, that let's not burden the training centers alone with the subspecialty skills. We should have a way of rolling out these skills over and beyond the national foreign training academic institution. So that I always see it in urogynecology that they have pools of patients in different regions. We have the Soroti team, we have the Mitiana, we have the Karamoja. Yes, but there are regional hospitals in all those areas. Why don't we have the skilled people in those areas so they can cater for the patients in those areas, instead of having an additional cost of incurring a transport refund, boarding fees, and people come to Kampala and get mad. We could, if we had, I think the strategy should be that we should find ways and means of extending these services or training or skills to the regional centers. And just a small advice. Yes, we have the numbers of patients in some of the centers like Kawempe National Referral Hospital, but we should not forget that the quality of the service will grossly improve if we went into subspecialties, even at national level, despite the challenges we have of the big numbers. Let's not undermine the subspecialties at the national level. That's the only thing which makes a difference between a district hospital and a national referral hospital. If you can demonstrate a clear difference in outcomes between a district hospital and a national referral hospital, and that difference can be measured by the skills that are available at the national referral hospital. In terms of training, I would therefore propose that the universities spearhead the development of curricula for those subspecialties and collaborate with the hospitals to make sure that the fellows get the necessary skills that will make them better at that trade. In terms of regulation, I think Dr. Wasa is, I don't want to call him old school, but there's this new school where everyone getting anything wants independence immediately. If you get a computer, you become an expert on WhatsApp, on Twitter. Well, we have to live in both worlds. But in my opinion, if we leave it to grow like that there's an association of laparoscopy, then other people who are not primarily the obstetrician gynecologists are going to take over the training of the subspecialties. I'm not being selfish, but I would rather that we have an obstetrician gynecologist first trained, then they go into the subspecialty. And that would mean that we can still have the AOGU, a unity in diversity. Yes, there's a subcommittee, which is gynecological oncology, benign gyn, reproductive endocrinology. As we build more and more people who are going to fill up those positions, eventually they will bud off and grow and become independent. It's not like someone is stifling their growth. And the beauty with unity in diversity is it gives you a better bargaining power. If it is AOGU presenting a case for subspecialty training, it will be different with the Uganda Laparoscopic Society presenting a case for subspecialty training, including bargaining with institutions like Cairo Medical, which have the equipment. AOG would have a better bargaining power than a single subspecialty. So in my opinion, I feel we should, in the meantime, nurture that growing talent and make sure more and more people go into subspecialty training, develop that skill from the center and take it to the regional centers. And the more people you have, the better the pollination of the ideas in that particular confine. We'll continue working with the Uganda Medical and Dental Practitioners Council and developing curricula for the fellowship training. We currently have some in Makerere. I think this should really get out of, be also in other universities. We currently have a fellowship in maternal fetal medicine, but we don't have enough teachers to train the fellows. So that's what we are trying to work on with Minister of Health to see that we can train more fellows in maternal fetal medicine. Those will be the nucleus of future training of MFM fellowship in Uganda. As a last thing, we have to not forget that a specialist, a first specialist alone without support is as good as useless. So we have to really be very particular in training these first specialists, plus the midwife, plus the nurse, plus the theater attendant, plus the equipment maintainer, plus everyone, so that we have a team that is going to function. Thank you very much.
Thank you so much, Dr. Sechikobo, for the wonderful submission. I'll allow my president 2 minutes to really advocate having the resources in the room, probably to pass this message on subspecialization, and probably give concluding remarks, and then I can come back and okay.
Thank you, Chair, for allowing me to take your space. I'm honored to be in this room where I see all the resources we need to successfully secure the future. I will start by asking how many of you are senior consultants, both active and retired? Dr. Beza, I don't see your hand up. How many of you are professors? How many of you are consultants in this room? The government guys, the hands of a structured hierarchy. I see my colleagues there. How many of you are special grade? There are so many there. Much as we share a qualification, we don't do the same work. So the 1-star general, the special grade, should not think they are as important as the consultant, who is the 2-star general. The 2-star should not think they're as important as the 3-star, who is the senior consultant. So I'll talk briefly about super specialization. A super specialist is someone with advanced knowledge and skill in a particular area of practice or a subject, and they spend at least 80% of their time doing that work. I'm a gynecologist. I should not do more cesarean sections than Dr. Waswa. There will be a problem. So I think since we have templates in our referral hospitals, we have reproductive endocrinology, I'm hearing there, we have MFM. It would be wrong to find reproductive endocrinologists doing more cesarean sections than the MFM people. It means there is an inherently structural problem in that institution. So super specialists, as Dr. Sechikobo said, they greatly improve outcomes. I do call in Zambia Hospital and they ask me to manage severe preeclampsia, which I see once a month. And I tell them, no, I have to call you in the night because you, the MFM person, will improve the outcomes for this woman. That is what you do on a day-to-day basis. So we must understand the role of super specialization. I'm referring people to Mulago, to Kawempe, because I know the colleagues there do that role well. I will then go into the roles of the 3-star generals. I call them the senior consultants. I think part of the biggest problems in the country are with that position. They haven't been empowered to do their work, or they have been abused into submission not to do what they're supposed to do. If you read the adverts and the job description, their job is to ensure, and ensure means make sure, ensure the delivery of quality O&G services, either in the region or in the country. So their job is not manpower of doing cesarean sections. Making sure is strategy, policy, holding meetings, budgeting, leading teams, appraising others, and aligning implementing partners to the Ministry of Health or the regional agenda. Now, many of our senior consultants are stuck in doing cesarean sections because they're being compared with special grade. They're not there for manpower. They're there for strategy, policy, implementation, training, things like that. So their appraisals should be, what is your plan for the department? What is your plan for the budget plan, budget framework? How many policies have you done? Research agenda, where? Not you didn't do call and do 5 scissors. Then we have the senior, we have the consultants. Many of them, that's at my level. We sometimes think we are also big people. Our work is to supervise the providers, and the providers are the special grade. So without a supervisor is somebody who has in-depth knowledge of a topic, and they can teach it and mentor and make sure that somebody comes out with the core skills. Now, the senior consultant, I think the word should now be the office of the senior consultant, because they should be given facilitation to do all those things, to ensure that things move. Now, for us, the supervisors, we train people hands-on, and ensure that when we're reporting to the senior consultant, this person is ready. This person is support supervision as well is a function of the consultant. But the support supervision plan is the function of the senior consultant. Then, of course, there are some of us who are young tax who like to grow, saying like independence. we are adolescents in the disciplines, the special grades. Man, you have to be fit. Our work is manual. We're supposed to cut scissors from sunlight to sunset, because you have to get the skills so that you can, in the future, when you become a consultant, train. So your outputs are more manual than supervisor, more manual than the senior consultant. So until the colleagues learn the roles and the directors and supervisors and others assign them those roles, then things will not work in these institutions. Then, of course, we have the foster generals, the directors. Many of them are being forced to do the work of the senior consultants because we are not planning for the departments. They're not making budgets. We are not planning for equipment. They're forced to then do some of our work, and they leave out their work of supporting us to actually deliver on services. So I think as we go into super specializations, if you're special grade, please sweep the floor and sweep it very clean. If you're the consultant, come and check if the floor is clean. If it is not clean, show me how to clean it very well. Then the other guy will make the cleaning schedule. You have to clean 4 times a day. We need soap and water. We need jelly, and then we need somebody to supervise the cleaners. So as obstetricians, gynecologists, at the different ranks, whether professors who are at level of ensuring, make sure services run well. So when you visit facilities, you find the senior consultant is proud to bring you the theater book. I'm the hardest working, I'm doing 20 scissors. So who is planning for the department? The special grade is the one running support supervision. Where is the consultant? There's no budget plan. So I want to encourage people to actually focus on your role. I was always taught, be a star in your role. So if I am the cleaner, I must be a star as a cleaner. If I am the supervisor of the cleaner, I must be a star as a supervisor. When I become the senior consultant, I must be a star in my role. So the senior consultant should not be stars in cleaning and compete with the cleaners. The consultants should not be stars in cleaning and compete with the cleaners. Know your role. Know your role. As AOG, we shall back you up. We shall advocate where we think that our seniors are doing tasks as opposed to doing strategy. Then we shall come in. That also comes in line with regulation. The senior consultants are the custodians of the profession. So regulation is the role of the senior consultant. Thank you very much.
Another round of applause to my panelists that have. Yes, let me take this opportunity once again to reintroduce and appreciate the panelists. Dr. Sechikubo Musa on my extreme left, Chair of the Department of Obstetrics and Gynecology, Makerere College of Sciences. Thank you very much. Dr. Olive Sentumbwe, WHO, a member of the association. Thank you very much for the contribution. Dr. Navunya Evelyn, the Executive Director, Mulago Specialized Women and Neonatal Hospital. Thank you very much. Dr. Christine Bidiabarema, thank you very much for the wonderful presentation and the contribution. Dr. Waswa Salongo, thank you very much for the marvelous contribution towards the topic. And second, last but not least, Dr. Musana, thank you for the contribution. Dr. Katumba Sentongo, thank you very much for the excellent discussion and submission. This ends this session. Next will be break tea, which will be probably working tea. We've used up a lot of time. It's coming to almost midday, about 15 minutes to midday. I beg that members will be given coupons from I think the Secretariat is working on that. And then we can pick the teas and then probably come in and join the discussion and the next session. Also, for the part of those that procured stalls, dear delegates, you're encouraged as you stretch your legs, kindly pass by the stalls and really enjoy the services that are being displayed and probably shared at this conference. In particular, there is one that is Stars and Philips Pharmaceuticals that are offering free random blood sugar testing for the delegates. So kindly members, before you take the teas, feel free to first check your blood sugars before you really, delve into the teas. Thank you, members, for listening. Over to, let's go for a break tea. Thank you, members. One of us to represent the ministry. At 2 p.m. Okay, worry. No, okay, before starting, before starting, just before starting the session, sure, no, the book will become my lesson. We're following up on the events. Yes, sir. We have announced that we are among the stall setup. The standard Philips, and they go and check your blood sugar before the tea. Professor Peter Waiswa. So dear members, delegates, can I give you a minute, please, to resume your seats? Take up your seats. So you're most welcome to this session, the session on official opening and the keynote address. So the members that are to partake are the conference chair person, the AOGU president, and then the keynote speaker. So dear President, can you please step forward and as we resume the session. I'll straight away go ahead to give my address to the delegates here today. AOGU members and delegates of the 17th Annual Conference, thank you for sparing time and honoring the invitations. To the organizing committee and the scientific committee for making sure that this conference takes place. To those that responded to our calls for abstracts and sharing in your research findings, thank you so much for this has also rendered the conference a success. I find the results that you're sharing, inputting to the theme, the conference theme of securing the reproductive health future of women in Uganda. Thank you so much. This will go a long way in advocating policy formulation, identification of such areas in reproductive health rights amid this increasing poverty, the higher burden of currently the pandemics that are on the rise and epidemics. We have just lost in the country close to 3,300 lives due to COVID-19. We are currently experiencing another outbreak of Ebola virus disease, actually caused by a strain of Sudan virus hemorrhagic fever. And it's also taking a toll on service provision for both, especially the most affected area is the reproductive health. Now that we have restrictions or lockdown for the two districts of Kasanda and Mubende, we already in the 27th day of the lockdown and of the extended more 21 days. So they have 42 days to go. Pregnant women and those that are seeking reproductive health services are changing some challenges. Health workers too are facing challenges, but I pray for the good that This would not hinder service provision, reproductive health division services in this area. Allow me in a special way thank the leadership of the Ministry of Health, who have actively engaged frontline health workers, especially those in maternal and child health division, in an attempt to get the root cause of the high maternal mortality and deaths reported in the mortality reported in the country, and instituting or encouraging institutional corrective measures to address this bottleneck. This has seen their birth, giving birth to at a national level, NASMEC and local maternity systems in all regions of the country to ensure that specific missed opportunities leading to the maternal death, prenatal deaths are addressed within these regions. The engagement of implementing partners or health partners with set deliverables in the regions has gone a long way in improving the quality of care that we are offering in the country by the frontline health workers. In a special way, I wish to thank the government of Uganda that has enhanced the remuneration of scientists and especially us, the health workers. We really thank the government for that effort, and I believe that we should also really pay back by doing what we're supposed to be doing in our regions, but also in the institutions we are working, such that at the end of the day, we should see an improvement or a reduction in mortalities and morbidities so far recorded in the country. Finally, I wish to encourage all potential researchers and innovators in maternal and child health that and those investing in procuring minimally invasive equipment to scale up in innovation and that are helpful in automating and making our lives easy for us who are doing what? Serving at the front line. Lastly, allow me to register my sincere appreciation to the AOGU executive that entrusted me to chair this scientific conference, and really the secretariat for putting together what we have to present and share, and properly organizing this conference. To you, the funders, those that have purchased stalls, and every one of us who contributed in any other ways to make sure that this conference succeeds. We are highly indebted to you, and we thank you so much. May God bless you all as we sit in to deliberate and probably pick something at the end of the day, being able to improve the quality of care at our institutions where we work. Thank you so much. So at this juncture, allow me to invite the president to give his remarks to the audience. Thank you.
Thank you, Dr. Kazibwe, the director of Specialized Hospital, Dr. Nabunya, Dr. Olive Sentumbwe from the WHO, Dr. Wise, our keynote speaker. We thank you for your presence, all the senior consultants here, the conference chair, all the members of AOGU. We are here to deliberate about how we secure the future reproductive health future of our women in Uganda as an association, and AOGU has a role to play, and it plays that role through its membership. AOGU's vision is to be leaders in reproductive health in the region. So AOGU is targeting each of its members to be leaders in reproductive health wherever you are. If you're a clinician, lead. If you're a researcher, lead. If you're an administrator, lead. And our mission basically is to advance services through excellence in practice, education, and we have members in training here, research, collaborations, and advocacy. AOGU has, over the past 1 year, gone so much into advocacy because we need to be visible and aid some of the things that we need to do. So the 4 areas, AOGU is 37 years old this year. It began in 1985. Some of the founder members are still alive. I haven't seen one here, but the 7 founder members, what is it? I've not seen her. Dr. Christine, yes, so some of our founder members are around and still going strong. So we owe to them to improve the AOGU and our service as we go on. So AOGU is a membership-based professional association. So you subscribe as a member and then we deliver on a mandate. So please, our members and associate members, please register. So the role of AOGU is not to provide services. Our role is to provide strategic leadership. So AOGU will not do the cesarean sections, but it will provide strategic leadership to improve service delivery in many of these areas. So how do we provide leadership? One of them is to increase access to O&G services. I am glad we have training stations here. Every year, I think Mulago Makerere, Mbarara, Nsambia, and KIU are producing close to between 40 to 60 specialists graduating every year. So there is no longer a reason to say we don't have enough manpower as obstetricians. The manpower is there. The issues are not being recruited or being distributed around the country. So we have the manpower. The other one is wherever we have services is to increase access, so the quality of services. And that's why I was looking at the senior consultants to improve the quality of services. Then of course, our human resource in service, must be of quality. So once I train as a specialist, that's how we're going into super specialization. So our human resource in service must be bettered. Thank you. So what are the policy agenda for AOGU? AOGU is directly getting involved in evidence-based safety bundles that are known to reduce morbidity and mortality because of pregnancy. So AOGU through its members, PPH committees, abortion committees, and so many others, PET committees, we are doing a lot of work there in access. I think, and our partners, WHO, fairing, we've been disseminating these deadlines. We want to make sure that every Ugandan woman at least can get to be seen by an obstetrician. The numbers are now there. The issue is now, can they reach to the lower levels? Many of our members in the universities in implementation are doing research to inform practice. I think this is the first year where I have seen a lot of our research being used as part of the guidelines. So this is a big step. Of course, to also inform policy and programs. Then our networks, we don't work alone. We work through and with our partners, the WHO, the Ministry of Health, CHI, the midwives, and others. So our networks must be strong. Then, of course, advocacy. I think many of our members can't speak the things that we can speak as AOGU. Whether in administration, we shall speak for you to make sure that you can deliver services right. If you're a clinician, we speak for you on key issues that matter for our members, but also for the country at large. Then there's an area that I think many of us have neglected, the adolescents and the young women. I think as we speak about specializations, we are requesting, I think, the key referral hospitals to develop adolescent and pediatric gynecology as a specialty to serve our girls and young women. Where do you find the AOGU members? Where do you find the obstetricians? Some of our members are administrators, like the directors here. Some of them are researchers. Some of them are in academia, and some are in policy making. So all our members are in those areas. And of course, many of them are geared towards supporting the clinician who delivers the services. So the clinician is at the center of that, but all our members are in those 5 areas. So we expect that as we advocate, as we improve programs, as we improve policy, we are doing policy for all those 5 areas to ensure that we deliver services to our members. So what are we advocating for as the structure at our hospitals, regional hospitals? We advocate that we have 2 branches, which is obstetrics and gynecology. And under obstetrics, we're advocating you have at least somebody for MFM and somebody for general obstetrics. Then under gynecology, oncology, urogyn, general gyn, and reproductive medicine. We are hoping that Murago Socialized Hospital will provide the template for how we can grow our services, including regulation and other things. So we're looking forward to working with you to develop that template that we can then push on to the other hospitals. Then, of course, we come to the human resource, which is my last slide as AOG. We have leaders in every area. We do have the senior consultants, and AOG is advocating that for each senior consultant that is employed, they must employ at least 2 consultants for them to supervise or to oversee. And for each consultant, at least 2 special grade to oversee. So a senior consultant obstetrician, their team should consist of at least 6 specialists to allow them deliver on their mandate of making sure that services are delivered. If there is no senior consultant, then the consultant can take up those duties as they mature into the position. So at the level of regional referral hospital, at least the department of O&G should have a minimum of at least 14 people. So I hope that as we secure the future of our women, we secure the future of our human resource to serve those women. So as AOG, our advocacy is around improving the human resource structure, improving the excellence in the 5 areas, administration. So we must support our administrators. As we attack them, it is offer them solutions to improve their work. We must support our clinicians. As we attack them, also offer them solutions. We must improve our research. We must improve our policy making, and we must improve our collaboration with our partners. I would like to thank you all.
Another round to the president. Yes, thank you so much. Next is to present the keynote speaker, and the one who go ahead and officially open the conference. Ladies and gentlemen, dear delegates, I present to you Prof. Peter Waiswa, who is an associate professor of health policy planning and management of the School of Public Health at Makerere University College of the Sciences. He is a visiting researcher at Karolinska Institute, Sweden. He's a globally renowned scholar with over 150 publications. With us, Prof. Peter Waiswa routinely advises government, WHO, the UN, the Gates Foundation, the World Bank, and many more on issues of healthcare. He's an academic who has engaged in lots with the community development projects, and as a founder, a member or board chair of the various local and international charities, he started and leads the Makerere University Maternal, Newborn and Child Health Center of Excellency and the in-depth network maternal, newborn and child health research group. Both organizations are doing research, capacity building, and global and local policy influence. He is also a co-founder and chair of the Busoga Health Forum, a national NGO that mobilizes health workers to improve health for most of our vulnerable of the vulnerable in Busoga region and beyond. Prof. Peter Waiswa is a winner of a Presidential Independence Heroes Medal and is also a member of the Uganda National Academy of Sciences. Ladies and gentlemen, I present to you Prof. Peter Waiswa to address us and also officially open the conference.
Good afternoon, members. The Director, Mulago Women's National Hospital, Dr. Olive Sentongo, the President of AOGU, and my teacher, Professor Dr. Waswa Salongo. It's good I came in a tie. I also came in a suit because you used to chase us, go and put on your tie. So Dr. Waswa, now you can say. And then members of the association, I feel privileged to be here to give a keynote address. Because one, I'm not an obstetrician, but it shows recognition. 2 weeks ago, I was giving a keynote address at the Safe Motherhood Conference. And this coming in a row, I think it makes me feel a little bit good. But also, when I was, could you put my slides, please? When I was preparing this speech or presentation, I knew the Honorable Prime Minister is going to be here. So I prepared slides to talk to her as a primary audience, but also to talk to you. And I hope the messages I have in my talk, those which are for the Prime Minister, Mr. President, you'll be able to take them to her. So they asked me to speak on, and I'm not sure I can say these things very well. If I can, let me just get my computer. It seems I'm dodging glasses because by this age, I should be having maybe glasses. But they asked me to speak about securing the reproductive health future of women in Uganda, which I thought is a good topic, but a bit challenging because it cuts across many things. I would like to give credit to some slides I'm going to use for some work we are doing with the MCHN project of FHI. So I want to give credit to that. That is going to be the outline of my presentation. I'll try to provide the context, give some recent UN estimates, and also estimates from Uganda, and the take-home message. As you might know, we currently struggling for data because our main source of data is the DHS, but it is quite delayed. And you know, DHS is good, but not so good. It's so it gives historical data, which is about 5 years old in many things. So although we continue many times making reference to it. So that is, I think, one of the areas of advocacy. We need the data, but of course we also have our own DHIS, which good enough has improved quite a lot. Now, when you talk about securing the reproductive health future of women in Uganda, the right organization for this work is the UN, and more particularly is UNFPA, and of course WHO. And they define this area of reproductive health in terms of sexual and reproductive health. and they define it as the state of complete, and I think for me that is one of the key words, complete physical, just like they define health, mental and social well-being in all matters relating to the reproductive system. So O and G, as you push your agenda, just know it is meant to be complete physical, mental, and social. It is not just the clinical aspects. It implies that people are able to have a satisfying and safe sex life, the capability to reproduce, and the freedom to decide if, when, and how often to do so. So I was happy when the director, the Women's Hospital, was actually talking about various specialties, plus the president, including issues of infertility for women, but maybe also men. I think we need to, I know there's a clinic for menopause, but maybe we also need our clinic, Madam Director. So, and when the women decide to have children, women must have access to skilled healthcare services. So one of the important things, they have the right to have children, to have safe sex, and also to have skilled healthcare everywhere. So when you see this definition, you move the slides, please. When you see this definition, next slide, please, if you can, because, okay, sorry, now it's moving. When you see this definition, reproductive health is comprehensive. It is a comprehensive goal that looks at the complete, remember the definition I gave, I'm not going to repeat it, physical, mental, psychological well-being as far as reproductive health is concerned. It includes a number of key areas. One is autonomy / empowerment and rights, including gender equality. So, members of AOGU, one of your agendas for advocacy apart from clinical skills is that people have their rights and women are empowered. Fighting poverty, illiteracy, and gender-based violence. So that is one area of women autonomy and empowerment. How are we advancing it? Are we even trained to have those skills to push for it? So those looking at changes in the policy, those are one of the areas. Can we change curricula so that our health workers are empowered to be able to provide these issues? Then there are issues of contraception and abortion access and care. And then safe obstetric and gynecological care. Those are the three main areas that they are advancing in terms of securing the reproductive health future of women in Uganda. Empowerment, autonomy, contraception, and access to safe abortion care, and also access to obstetric care, and of course, gynecological care. When I was, again, making the presentation, I tried to borrow some colors. I borrowed the color yellow somewhere because I knew the Prime Minister would be looking. And so what are some of the facts about women in Uganda? We talked about that one of the areas is empowerment. As you might know, the population is not uniformly distributed. There are more women in this country than men. Women are almost 51%. So they are the majority, meaning that they deserve a lot of everything. But also they do much more in terms of their household heads. There are several, in Uganda, household headship is almost 30% houses which are led by women. But even the other 70%, you could say they are co-led by women. So they are doing quite an important work. But also, unfortunately, they have lower literacy. And then in terms of physical and sexual violence, they are more abused than men are abused, at least according to data. Some men disagree. They think that we are more abused, but we don't speak out. To the extent that the most recent DHS found that the prevalence of physical abuse for women was about 22% in the last 12 months, and sexual abuse was 28%. And then women do a lot of unpaid work. So coming back to autonomy, empowerment, we can see where our women are, that it is not good enough. And if they are not empowered and they don't have autonomy, then the reproductive future may not be achievable. I bought this slide from UNFPA, and basically what it says that women are caught in a web of inequality. The gender equality, they are denied rights, insecure jobs, limited access to sexual and reproductive health care, the thing the president has been talking about, unintended pregnancies and HIV, exclusion from unpaid labor, limited education, and diminished capacities, insecure jobs, all of them which drive them into poverty. And they are caught up in that web. How do you navigate that web and get empowerment so that it is not us as health workers to guarantee women their empowerment. It is actually from ideal society, but we facilitate that. What is the role of AOGU in these issues? I'll be giving some ideas. Good enough, I've had some of them from the president. But women in Uganda are actually quite a lot in leadership. The proportion of seats held by women in national parliament is almost 35%. I mean, it is not 100, it's not 50%, but it is big. What are those women doing for women empowerment to ensure that their reproductive future is achievable? Even at lower level, they are even much higher, almost 50%. Here it is given as 46%. Even in terms of proportion of women in managerial positions or women in senior middle managerial positions, it is going up. We just have the director here as one of those. I think, director, you have a very challenging role. Good enough, you talked about some of the things that you need to do. And I think you can mobilize these men to ensure that these things are taken. Back in my Busoga, we would like to see most of these specialized services come to the region. So it is a national hospital, not waiting to receive patients only, but hospitals also play a primary care role or a community role and other roles. That is how we should be thinking about these. So how are these women in leadership helping push the agenda of women? So that is to do with empowerment on issues of autonomy. I can't say that I'm an expert on empowerment and the autonomy, but that is as given by the literature. Then something which is closer to us, contraception and abortion care. And this talk, I'm not going to be speaking so much on abortion, mainly because I don't have the time, but it is an important topic. But I'm going to speak about contraception. So as you might know, the School of Public Health leads what we call the PMA, which is an annual population level survey on issues of family planning and fertility and stuff like that. My colleague, Dr. Makumbi, leads that work, but he works with several organizations and many of you here. So for this area, we actually have data. And I try to simplify this data because, as I said, I was targeting the Prime Minister to see what can she take from my talk, because I didn't want to make it complicated. By looking at the trends in the use of contraception among married women 15 to 45 years. Over time, incidentally across the board, the good message is things are getting better. And I'm going to emphasize that word, that things are getting better. And we congratulate all of you for the work you've been doing, but it's not enough. As you can see, over time, I want you to focus on, is it the pink, modern contraceptive prevalence rate? 2018, they found about 36%. 2019, 35, 2020, 37. In other words, these 3 years, you can say the contraceptive prevalence rate was the same. We are working but producing the same result. But 2021, it actually, they found a much higher prevalence, an increase of 5%. Congratulations. If we can do that within a year and continue improving like that, I think in the next 10 years, we shall make a reversal on access to contraception. But are we putting in the right efforts? Right now, in many places, there is actually a stock out of some of these things. All health workers are not reaching everybody. So we have the data. Can we act on the data? Women with the most recent pregnancy, which was unintended, these are women who were pregnant, but they never wanted the pregnancy. Again, here you look at the green is rural, the pink is urban. The data is from PMA. And with time, we see that there has been a bit of improvement in especially the urban areas. But rural areas, the unintended pregnancies are actually going up. And this group is a lot contributed to by adolescents. Overall, 46%, almost half of women who are married, women with the most recent pregnancy, they never wanted the pregnancy. 13%, they never wanted actually completed the pregnancy at all. They never wanted any more. 33% wanted later. This is a great opportunity for public health. What are we doing to get these people who don't want pregnancy now? I think they are ready actually to use contraception. So one of my key messages is that, which I'll be alluding to, is that we need to change strategies to target people more, identify people who actually are ready, and we give them contraception. And then for the others, we try to convince them. So for me, I don't like the word unmet need, because unmet need means that people want, but we are not able to provide. I think this is simply not acceptable for public health. And it is a challenge to me, it's a challenge to all of us, that women don't want, half don't want the pregnancy, but we are not able to provide the contraception. Mr. President, what can AOGU do? I think as I present these are some, you should be answering this question, and not just for the president, but for everybody in the room and beyond. How about unsafe obstetric care? And again, gynecological care. I'm not going to be able to speak about gynecological care because of time, but the experts are in the room. And when you look at safe, the data, we don't have updated data in terms of population level data. So we have Dr. Sentumwe's estimates, the UN estimates, WHO, UNFPA. And the figures say the maternal mortality ratio in Uganda by the UN estimates is about 375. But look at the range. By the way, when you read this data, don't just, as scientists always question the data, look at confidence intervals. It could be anywhere between 278, which is good, but it could also be 5 to 3, which is almost several times, almost doubling what we report. So, and still, when you look at the data from the UN still estimates that 6,000 women die in Uganda per year. So you can go back to the figures. So we've made progress, but because the number of women giving birth is actually increasing, we have not reduced the absolute numbers of women who are dying. So again, Dr. Musana, good job, but we need to do more. The curve above here shows, it is the UN, just focus on the top one. The top one shows maternal mortality from around 2000, from about an estimate of 578 to 2019, when the UN released the most recent estimates, which was about 375. Some progress, but look at the bottom. The bottom is for child health. That top bottom graph line is for, this one is for, is for under 5. We are able to reduce the number of children dying, especially those above 1 month, but not so much for mothers. The curve for mothers is almost flat, and for children under 5 is not. And I usually ask my students why, but you are not my students. So although some of you have been or are applying, or a few of them, like the one I was sitting with, is the main answer is this country is so good at managing simple things. Okay, sometimes anyway. Things like diarrhea, immunization, we are good at that. But imagine a mother who is bleeding. So Dr. Sentumbe and others, how do we manage a bleeding mother? Do we have a system that is able to manage that mother and avoid the death? That is the number one challenge I want to give you. We don't yet, and I'll be emphasizing that our capacity to do immunization, distribute bed nets, treat fever, well, somehow it's good. But for women, when they are bleeding, they actually bleed to death. Okay, most of them, some of them. We have actually improved, but not good enough. The job, Dr. Musana, is yet to be done. We still have a big job. And this is the same reason we've not made a major dent on newborns. Because a baby dies within about 5 minutes if it's not breathing. So you need a system. Do we have a system? This is the system test. Do we have a system that can work in 5 minutes for a baby who is not breathing? Or in 30 minutes for a mother who is bleeding? I think this is the greatest challenge that the country has. So, but data from GHIS2 shows that actually in the last few years, Uganda has been reducing maternal deaths in hospitals. Almost a 30% reduction in hospitals in the last few years. Congratulations. So this is a good thing. Please, let's clap for ourselves. Because so the system is beginning to learn, is beginning to improve, but as we will be seeing in the next graph, which we've done from the MCHN project, over time, from 2016, 17, and you see the top graph shows the rate, the institutional maternal mortality ratio has been going down, but not as fast as we would want. At the bottom, in the figures in red, shows the number of maternal deaths in hospitals. In 2016, 2017, those were reported were about 1,120. In 2021, it is 1,226. So whereas the rate is going down, the absolute number of mothers dying within our facilities is not necessarily going down. Of course, because there are more women giving birth. As you can see, in 2016, there are about 1 million births, but now the estimate in Uganda is we have maybe 1.8 births a year. Of those, about 1.4 million are reported in the HIS2. So we are doing a fair job, but the numbers of the people who need care are increasing. Have we increased the system capacity, including human resource, commodities, and issues like that, and expertise? So progress, but are we happy with it? Are you happy? I'm asking a question. Are you happy? Look at where these maternal deaths are happening. The red shows those areas that have quite a high number of mothers dying. Of course, this is always complex because regional referral hospitals and tertiary hospitals, because of referral, tend to accumulate the numbers which are coming from somewhere else. I think we should account for every death from where it is coming from, and that facility be able to account for those deaths, not just sending to Dr. Kazwe here in Kawempe. We've actually done an analysis of deaths of mothers at Kawempe and mapped out where are they coming from, which facilities are they bypassing, and we have a report and even a policy brief on it. So the deaths are all over the country. I think that is the message. All over the country, there are maternal deaths. We see them in some specific areas, but if we are to intervene, we can't just say we start from this area. Although I'm going to tell you later that most of the deaths are here around us. They're in Kampala and surrounding areas. So if most obstetricians are in Kampala, then accountability is needed. So, Mr. President, you have to be angry and ask your staff and others that, no, this is not acceptable for this mother to die when we are here. What are they dying of? The message is the cause of death has not changed. In WHO right now, and I happen to be actually advisor to the WHO Director General. We have a meeting starting on Monday on the same. And we've been discussing obstetric transition, which is basically that there is a transition from common causes of death, like bleeding and sepsis, to more of these which are on the right, pregnancy-related and other indirect causes. But Uganda has not completed a transition. There are some countries that have transitioned. And if there is a good facility in Uganda, you should be able to see an obstetric transition. When you see that the death from postpartum hemorrhage has adequately gone down. Over time, there's been some improvement from 39 in about 2018, 2019 to 34. But over 4 years, that is the improvement we can make, and we are happy. So we've improved, but not enough. So we are working. Congratulations to us, but I think not good enough. We need to do more. Of course, one of the biggest problems is adolescent pregnancy. This is data we analyzed some time back during COVID, and it shows the rates of adolescent pregnancy in regions. And what is interesting, Chikezi, Karamoja, Ankole, Kampala, and South Central region have much lower, but the rest of the country, the rates are so high. And you can say the rates follow rural areas and poverty. So we started by autonomy, empowerment, and the issues like that. And this figure is a confirmation of that, that without addressing the other determinants, we call them the social determinants of health, will not make much progress. So that is one of the areas that we need to be focusing on. Now, the country is doing very good work on MPDSR. Again, congratulations, thanks to the ministry and its leadership. I know behind the scenes, the MCHM project, which I also work with, we are producing some of the data that is used. But And they always say the but, that when you look at this data, some of the reasons women are dying are simply not acceptable. There is no blood, no sutures. Can you imagine? No sutures. I want to tell this to the Prime Minister. And that how can this be acceptable in a country which is going to the moon? You know, we launched our satellites. We must go to the moon, but also do the simple things. No gloves, no electricity, no anesthesiologist or anesthetic assistant. Dr. Sentrumbo, we must fix this. I think we must handle emergency care as emergencies. And the bad thing with emergency care in obstetrics, they're always there. So you can be more prepared, not like Ebola, which comes and you forget. These ones are coming even this second. Really, the system cannot learn and be able to prepare. I went to Tanzania, to a hospital in Tanzania, and you know what they do in this hospital? They prepare a kit, even and they tell a patient, I mean the family, that you need this kit in order to save the mother. We are going to use it, but actually you are going to replace it. So they don't wait. But in Uganda, of course, because of corruption, all these things are not accepted. But one of the things they do is that they have emergency prepared kit, prepared for C-section or for emergency. Always there. They don't lose time go and buy Gendo Gule. I think Gendo Gule should be a movie in Uganda. Go Gendo Kulechi. Gendo pharmacy. It's become a norm. I think it should become a norm for like a cough, but not for woman bleeding. So obstetricians, this is one of the things we must advocate for, that they make your life so difficult. I've always said, how can we mobilize super specialist or consultant and then be able to fail to mobilize a suture? Which one is more difficult? Surgeon is waiting for hours to do their stuff. I think this is not just acceptable. And our country must change. And I think if we continue accepting things, that's part of the problem. And then mothers die because of these famous reasons. So one of the things, we need to take our fight outside the health sector. I'll be coming back to that point. That when you look at blood, which you say obstetrician need blood, but look at most regions that have all these problems don't have a blood bank. North Central, Busoga, Lango, Chigezi, Bukedi, Bunyoro, Teso, Karamoja. I know there are a few, about 2 which are being built. I think Karamoja and somewhere else. But I think this is part of the advocacy. You should almost demonstrate on this, that if you don't do in the next 2 years, we stop operating. Because how else do you, I mean, you can manage a bleeding mother, some without doing blood transfusion, but for others, you have no choice. So I think we should demand for some of these things. Yeah, I presented this graph to the Safe Motherhood Conference. So for some of you who attended, it's a repetition. But important things must be repeated. 6,000, around the time of birth, 6,000 mothers die a year. Then we have 33,000 newborns who die, and almost 30,000 stillbirths. Combine them, they're about 69,000, 191 a day. You can look at Ebola, put accidents, put a COVID, you never reach this number. These are people dying. I was showing my students yesterday when I was teaching, I used to say also. I said, you know, can you imagine pregnancy is like a war? Because if mothers are dying this much and babies, then there is no bigger war we have every day. But we are not actually managing it as a war. Or if it's a war, then we have accepted defeat. And if you accept defeat, then we don't need to be here. 190 a day because a woman was pregnant, and then they lose babies, and we are sitting back. So I remember a couple of years ago, I was in a meeting, and I met obstetricians and pediatricians and others. I said, why do we accept these numbers? I said, by the end of the day, for us, we are so tired. We want to prepare for the next day. I realize we are talking to ourselves, and we are talking the wrong group, the group which is convinced that things should change, but they don't have the power to change the things. So actually, I went to law school. If you that suing of the government on maternal deaths, to some extent, I was behind the scenes. But I thought lawyers would help us a bit, not to sue doctors per se, but to advocate for the system to empower women, to look at issues of women. And I went to the Constitutional Court actually to give expertise, which they ordered the government to do a number of things. Dr. Centrum, we should use this ruling, it's a constitutional ruling, as an opportunity for advocacy, but also for engaging government and building the system. So this graph is for child death, which is, you know, the reason women are pregnant is to give birth to babies. I think there is no other reason. Is there another reason? They get pregnant in order to have babies. So when you look at maternal child death, Kampala, if you look just at the end, is the death of children in Kampala is almost the same as rural areas. But I don't have the same graph for maternal deaths, but the numbers are basically the same, that maternal deaths are also here around us. So I just wanted to confirm what I had said before by showing some data. So then what can obstetrician do? So I think from what I presented, we started by saying that one, things are beyond obstetrics. The women die, one, because they are not empowered. They are poor, they're illiterate. So addressing the issues of underlying issues is going to be important, and that requires a multi-sectoral approach. And the question is, good enough, Doctor, you talked about advocacy, but where are you doing your advocacy? Just the Minister of Health? We need to go outside the sector, because issues of trying to engage. And I asked Dr. Professor Ada and Dr. Noe Nikaleva one time, how did you people get HIV on the agenda when we didn't have antiretrovirals? And it was in a webinar, a seminar, and they said, we used to jump on the tables as activists. They used to jump on the table that we must access antiretrovirals when the world was saying that Africa cannot manage antiretrovirals, just like they were saying we can't manage COVID vaccines and all those things. So I think advocacy, Doctor, you said you are doing advocacy, but this is an area where AOGU needs to do better. And even we need to be trained more and maybe to make those linkages. And I wanted to make reference to Professor Pius Okong, who is a member of your committee. Pius is a silent advocate. One time when he became head of the Health Services Commission, he went around the country and documented that health centers 3 and 4 in Uganda don't have enough health workers and they are collapsing. He went to Parliament and told the MPs that your constituencies are in trouble. He talked to them, something which affects them. And went to he went to the minister and of finance and the PS there. And the PS said, you are the only doctor who has ever come to us to show us why we must invest. The government, the president was actually saying we can't recruit health workers now. You remember that fight? But his own party said that you must recruit. Otherwise, you are not passing the budget. That is advocacy. That year, the government committed to recruiting 10,000 health workers. And actually, they ended up to recruit, I think, about 8,000 because there are not enough to go around the country. Smart advocacy works if you know how to do it. You must convince members of parliament good enough, like we talked about the women's hospital. That was advocacy. That kind of advocacy we need outside the health sector. But we have the expertise to do advocacy. On contraception, we've seen the figures. And one of the things women complain about is the bad contraceptives. I don't know when we are going to, the whole world doesn't. The rest of the world, the more developed countries, don't have necessarily bad contraceptives. But here, we've sort of accepted it. I think we must challenge the status quo. But most importantly for me, okay, they are not bad per se, but in terms of side effects, I think we need to learn how to deal. Actually, in Osaka, we are doing a project on family planning, and we call it Amazima. Dr. Kakaire here is involved. We talk about side effects clearly, and the people, because when you tell women there are no side effects, or they are normal, and they have been experiencing them, then they will not trust you. But if you speak Amazima, then you can deal with the issues. If I get a problem, where do I go? But most importantly, what I wanted to say is we should not accept the contraceptive prevalence rate that we have in the country. Women are willing to use family planning. Can we devise methods for reaching them? Can we do better methods for identifying those? We said 46% didn't want the pregnancy. Those women are still there. Issues of adolescent health. 1 in 5 of pregnancies in Uganda is from an adolescent. And they are now contributing significantly to maternal death. And you know, we've been dealing with this issue of adolescent health, hiding our heads in the sand as if it doesn't exist, as if they should not use contraception. I think we must come out that those adolescents, at least a starting point, that are sexually active must be allowed to access these things. And until we speak, as you people who manage these conditions, because me I'm speaking, but I don't manage them physically. For you, you do. And you know how you deal with those issues, how you struggle. Those who are sexually active, we must be able to address, as we do, of course, the other interventions of abstinence. So for me, I think this is an important thing we must address. And yeah, so for us, we have a project. We are doing 2 projects. One is called ICANN and one is called UTP. We are trying to develop a human-centered approach to access to contraceptives so that interventions are better designed around the needs of the population. But without doing so, we shall continue getting women who are saying we wanted to use contraception, but we were never reached. Now, for all these things, currently WHO is recommending what they call 3 most important things. 1, a life course approach. A second one is a more sexual approach, and the final one, a focus on service delivery. And in terms of service delivery, life course approach, they're saying we need to start doing adolescence. So this is a WHO recommendation which Uganda also adopted. And we start young when they have not even been pregnant, and then manage the pregnancy when they become newborn until they are young adults and big women. So obstetricians, you have a big job to do. It may not end just by delivering women. So the life course approach is being promoted by WHO for all issues to do with reproductive health. And it starts with adolescent health. Okay, sometimes it's not clear where it actually starts. And then this multi-sectoral approach say there are things we can do for individuals, there are things we can do at family level, there are things we can do at community level, there are those things we can do in the health system, and then things we can do like in schools and policies. Good enough, Dr. Musana said you're working on some of these, but I think the message is step out of the clinics a little bit more to speak to other people. Many people don't know where you deliver those women from and what you go through every day. If you tell them stories, they can't even imagine that you can cry that you didn't have gloves. Now, the numbers of women coming to deliver has increased, but where is the quality? And this is an important thing. Again, I'm repeating this slide from 2 weeks ago, which says in order to perform and to have impact, staff must be motivated. Okay, they have paid us the money, but is that enough? We say that money is not actually a motivator. For us in public health, we say that is a sanitizer. It's not a sustainable motivator. Environment, how you feel at work, how you feel among colleagues, recognition, all those are important. But most important, the environment in which you work. But I wanted to focus more on competence. I think, who said it? Somebody was presenting that you can't, Dr. Sichkuvo, my classmate, was saying that we say this one is a midwife, this one is a doctor, this one is a specialist, but are they really competent? That is what Dr. Sichkuvo. Competence is going to be important. And I would like strongly recommend that we must develop a competence-based system for accreditation of health workers. It is not just saying I attended CME. Does attending CME mean that you can manage this breathing mother? So that is all they do accredit elsewhere in the world. You must show clinical competence. So I think they accuse us in the training institutions that we bring out people who are not competent. But like I said 2 weeks ago, don't register them until you prove that they are competent. And then we shall stop also producing them. So it will work. We need to work together to ensure that only competent people are managing patients. I don't want to spend a lot of time on UXC because UXC, Dr. Sentumba has talked about it in her remarks, that if we are going to change the situation of women, then healthcare must be accessible to all, and we must remove all remaining barriers, including cost. So how do we make healthcare more accessible to all is one of the key attributes of UXC. And I'm about to finish as I conclude. Again, this slide, I'm presenting it again, and this is the most important folder for me to present it. That healthcare is about standards, period. Isn't it, Doctor? It's about standards. Standards of cleaning the floor, of laying the bed, of giving the IV fluid, but also the delivery. Everything is a standard, is an SOP. But show me one facility in this country where standards are being followed. So number one is standards. You do standards before you do improvement. You must define the standards, implement the standards, you measure the standards, then you do improvement. But a lot of our projects and work is starting with improvement. So you do improvement on how to resuscitate a baby, and the environment is full of germs. Are you going? You save the breathing, but you die from infection because you are not doing standards. Let us go back to managing the health system the way it should be. Finally, in terms of conclusion, so I want to recommend that yes, we need to use data to diagnose the problem. Where is the problem with improving the welfare of women in terms of reproductive health? Have we analyzed where the gaps are and then designed programs based on data? And also the advocacy also to be based on that. If you got finance, they ask you, how much does it cost? So you are talking about, you want specialists everywhere, regional hospitals where finance is going to task you. What does it cost? If you find a specialist, he needs things to use. How much is it going to cost? Can you give us the figure? And how many lives shall we save? So, Doctor, I want to invite you to work with us in the School of Public Health because we can answer some of these questions together and for the good of the country. So use data to analyze, but also to advocate. The adolescent health issues, we must face them openly. And I think if for us we don't speak, nobody can be a better advocate than the people who are involved in managing the consequences. We need to address the underlying causes. That is a multi-sectoral approach, step out of our clinics. So here I would ask how many people are non-health and we might find we are just, there are just a few. We must learn to manage the healthcare system. Why should we run out of catgut? How? I mean, I like to challenge all managers. First, save for those emergencies before you buy Panadol and Septrin. Those people are not going to die now. Those who need Septrin. First, save for those emergencies before you go to other things. But there is a problem. You are counted. The government of Uganda assesses you on how many people did you work on without looking at the outcome. But at least let's advocate to change the league table. In fact, we have proposed the ministry that we are proposing a new league table. So I'm invited to a meeting tomorrow to present our presenter, Dr. Sentumbe. We must, it's not just acceptable. Then issues of competence. In the end, issues of governance and management are important. So all these things, eventually we have the skill, but we need the governance. And at the first rise for the Prime Minister. But I don't know whom I'm going to pick as the Prime Minister today, so that she hears this. But take the message. The contraception movement, I think we need to look at it hands-on. Just like we are trying to increase coverage for EPI, I think we should make the same effort in contraception. And this is a Prime Minister pushes for the parish model. I think they should not even give out that money without looking at those people, what they do. We are not saying that they should reduce the number of the population. Sometimes people misunderstand. They should just have better quality children. Dr. Kaziwe never mentioned that so far I've only made 3 and counting. So we can have a better population, which is productive. Let's allow sexually active adolescents to get contraception because they're already active. What can you do about it? And if they come asking for contraception, you'll be, I mean, it will not make sense if you say don't take it. If tomorrow she's going to come back pregnant or dying. We can't reduce maternal deaths. We say we want to reduce it, but then we don't do the interventions. We are shooting ourselves in the foot. Let's cure emergency services. I think I've said this enough. I mean, there is emergency preparedness, is it for outbreaks, but we have this epidemic 190 a day, and we are not prepared. And let's build capacity for the clinical services, train more people in hospital management, health center management, DHOs in management, so that some of these things are able to be identified. In the end, my final message is that one, let's step out of let's go and advocate outside to people who have the power with maybe somebody should build our capacity, but clinical services must be managed more. And then we need to do some things a little bit better and be more ambitious. Thank you so much. And they also told me to take on some new powers. So you've been asking who is going to open this meeting. And I've been given powers I've never had, except in my village. So with those powers given to me, I declare this conference open. Thank you so much.
If I required an energizer, I have now one. Those of you who have been thinking we have problems, we're going to become bigger problems because now we have some motivation to go out there. And some of the issues we speak about, I think we shall look to you to collaborate to ensure that we deliver a clearer message. I'm encouraging all the colleagues here to join me in giving a round of applause for Dr. Waiswa. So what I have understood is that we need to stop speaking to ourselves. We come here, year in, year out, and speak to ourselves. Let us move out there and advocate, and AOGU I'm committing the organization that we're going to go out there and knock on those doors to make sure that we pass on a message that will deliver Ugandan women and secure their future. I think one of the things you're going to do with Dr. Kazibwe is look for the Prime Minister. She was the former Minister of Health in general duties also. So I think we shall look for her, but also look for other powers that be, and hope we can bring in some of our colleagues here. As I've said, some of us can speak at fora because we don't get paid by certain people. So we can pick out those issues and ensure that at least the message is heard. So thank you very much. Thank you very much, and thank you very much.
So thank you, members, dear delegates, for listening in and probably you're learning. On the program, it's 1:30. I pray we engage into the next session on MPDSR. I pray the session chair, you'll really stick into that 1 hour we've allocated you, so that we can move on and try to catch up with the program. I now take this opportunity to welcome Dr. Mugabe Kenneth to take us to the next session. Thank you.
Hey, they're there. Yeah, good afternoon. Kenneth Mugabe is my name, from Mbale Regional Referral Hospital. The message I've got from Professor Waiswa is that medical services is about standards. And right now, the standard necessitates me to invite our next presenters to partake of their seats. Please, may I invite Liz Ayebare to take your seat. We are in for session 4 of our presenters. And Dr. Wanyama John, please, can you take your seat? Ariko Annette, Cole, Yale, Marlene Wilcox, and Dr. Namagembe Imelda. As we discuss maternal perinatal death surveillance and response, we are reminded that the government of Uganda is emphasizing that we must prevent, or we must stop any preventable maternal and perinatal deaths. And this initiative, just as a reminder, was inaugurated in 1998, and since then, things are getting better. And like you've heard, despite the fact that we have about 20 mothers dying per week, and about 190 newborns dying in a week, there's been a great improvement where we've seen reduction in 30% deaths in maternal mortality. So with us, we have our presenters this afternoon, and without wasting time, we'll give you maximum 10 minutes each. Please make sure that you keep time. May I invite Elizabeth Ayebare to present. Okay, please. Thank you. I will invite Liz Ayebare to talk to us about advancing care and support for women after stillbirth and early neonatal death, a feasibility study. You're welcome. Please, as you're presenting, have a glance in front of you to as they remind you of the remaining minutes as you present. Thank you.
Thank you so much, the chair, for the session.
and my brother. Thank you everyone who is present. I'm Elizabeth Ayebare, and I'm delighted to present on behalf of the NIHR stillbirth unit. And this study was done during COVID. We started in 2020 through to 2021. I'm waiting for my slides to be loaded. Okay, thank you. So I'm presenting about advancing care and support for women who have had stillbirths. Like we've seen that our neonatal mortality, our stillbirth rate is still really high. And like Prof. Waiswa has said, it's like a war. And when war happens, people remain with emotional scars that can cause lack of function in their lives. So this was a feasibility study to test 2 interventions that would support women who have had stillbirth or early neonatal deaths. Our team lead is Dr. Tracy Mills, and Prof. Tina Lavender is the head of the NIHR Global Health Stillbirth group. Next slide, please. Yes, so the stillbirth rate is still high. I've already said that, 17.8 out of 1,000 total births. And like we've said, the death of a baby is very traumatic. It's like war. I love that statement from Prof. Waiswa. It's really war. And we see that 60 to 70% of women who experience these losses end up with serious grief and prolonged psychological impacts. Studies have shown that 30% of these women experience intense grief after the loss. But these are people that are not, heard. They are not known in our setting. We have seen that these mental health issues that they suffer from sometimes go unnoticed. But studies have also shown that good psychological and social support can help these parents to adjust. So when we did a baseline study to understand the experiences of women, partners, and health workers for parents who wanted to know their experiences of loss and what they go through. And some of the needs we came up with is that there's lack of privacy, there's little information about what caused the loss, why did the baby die, there's little social support, there's also problems with respectful and supportive communication, especially in the hospitals, and also there's a lack of opportunities for parenting or feeling like this was my child. So, and then from the health workers, some of the needs that we found was that there was little education and awareness raising when it comes to caring for these parents. And there's little leadership and support at the facilities. And also there were lack of resources, which was always the reason why probably these babies have died, because they couldn't access a cesarean in time. And this really caused a lot of trauma to the health workers. So what are the interventions that we tested? So we wanted to test and see whether an intervention of having a bereavement care champion group, and also having a telephone peer support group could help to support these women after the loss. And this was really a feasibility study. We wanted to see whether this intervention can work and whether we can do research into this kind of intervention. And we did a training for both the peer support group and the health workers in January 2020. So the aim I've already kind of talked about our aim was to assess the feasibility of a bereavement care champion network and a peer support intervention to advance care and support for women who have had stillbirths or early neonatal deaths. And we specifically looked at the acceptability, implementation, and uptake of these interventions. Then we wanted to look at the impacts of doing research on the services at the facility, and also to look at the recruitment and retention of women and health workers in this study. So I'm just here clarifying the role of the feasibility study is usually to see whether this research can be done or whether the intervention can actually be implemented and whether it can work. So that's what we're really looking for, recruitment and retention. So in our approach, we used the mixed methods approach. It was a before and after study. And our study setting was China-Uganda Friendship Hospital, Nakuru. Actually, some of our bereavement care champions are here. The team lead for our champion is here, Sister Mwanguzi Sarah, she's here. So it's good to have her around. And the team lead also for our peer champion network is here with us in the room. And we recruited 60 women, 30 for the phase before intervention and 30 after intervention. This recruitment was done at 2 weeks after birth, and then we followed them up for those who received intervention after up to 8 weeks. And then we went and did an interview with them. Yes, so those who received usual care were 30 women, and this was before the intervention. Then the intervention group received a visit at 2 weeks to kind of match them up with a peer. The peers were women who have had a stillbirth before and were trained to learn, to know how to support these mothers. And then at 8 weeks, we interviewed them, and we also did looked at their depression scores and grief intensity scores. Yeah, that is again to show the recruitment. So this is what happened, that in phase 1 we contacted 42 mothers, and a few of them were excluded, some declined, some had issues with a phone, and then eventually we had 26 mothers whom we followed up. But at the end of the study, we could only access 22 because we were not able to reach some other women due to phone problems, and it was also during COVID, so it was a bit difficult. That is a picture of our bereavement care champions. Then in phase 2, we contacted 46 women, we recruited 30, and at the end, at 8 weeks, we interviewed 25 women. We had a few who declined to be linked up to a peer supporter. One declined, I think 2 of those, one of the women said she had enough support. She had her husband who was so supportive. And then the other one, I think, thought she didn't want anyone to interfere with her in that period. Then the other person had no phone. But on average, we had most of the people, 81%, accepting to have peer support. And this was delivered via telephone. And the average number of contacts were around 4. So they called, most of them were calling weekly, and they called around 4 times to get the support. So there were also some changes at the facility because we had a training with the bereavement care champions who were midwives at the facility. So there was a quiet space that was created to enable parents have some time with their newborns. And also there was support for women with IUFDs. They were linked from the antenatal clinic directly to the labor ward, and they would have someone to, support all through until their baby is delivered. Parents who wish to spend time with their babies were enabled to do so by the champions, and there was more awareness of the need for this extra support among the midwives in the facility. There's also improved communication with parents, since the bereavement care champions were able to understand the emotional issues that stillbirth and neonatal death brings. So we have a few quotes from the care champions, and I'll read one of the quotes. The second quote: "Now after the training, at least I take care of them as a priority. I handle them the same way. I don't discriminate. I used to give more priority to those ones with live babies, and I used to give less priority to these ones who don't have. Yet for them, their mental status is not very okay." So that shows us that there was some improvement. Then from the peer supporters, these are lay women who are supporting the mothers in the community. One of them says, I'll read Blue. She says, "When you listen to them tell you, you feel better because you wish you had had someone experience the same experience then. So it's emotional, but it's also rewarding. It feels good that you have made a difference." Yes. And then from the women, let me read Virginia in purple, in pink. She says, "So this lady also, she is now like my mother, because the voice she was using was a caring voice, a touching voice. So I was so touched and comforted by her. Indeed, I appreciate the advice she was giving me." So in conclusion, our recruitment was near target. More than 80% were recruited and retained in the study. Women who had experienced the stillbirth found that the care at the hospital and the peer support was helpful. And the study also revealed that the intervention is feasible and acceptable. And right now we are writing up a bigger study to actually test these interventions in more hospitals across the country. So I wish to acknowledge all the people who supported this study and our funders, the NIHR. Thank you so much for listening.
Thank you, Liz Ayobare, for keeping time. Without wasting time, I'd like to invite John Wanyama to talk to us about improved maternal perinatal birth notification and reviews at China-Uganda Friendship Hospital, Naguru, due to technology adaptation by midwives. Thank you. You're welcome.
Thank you, Chair. So I'm going to talk about how we have improved notification and reviews at China-Uganda Friendship Hospital by use of our midwives adapting to simple technology. I'm John Wanyama. I would like to recognize Mwanguzi Sarah. Mwanguzi Sarah, who is here with me, because she's part of this project, plus those midwives mentioned there, and there are others who have not been able to be with us here. Next. Next slide. We know that perinatal mortality is high. In the country, we are at around 38 deaths per 100,000 births. And the maternal mortality ratio is high, like you have heard from the keynote speaker. Of course, we have almost the same rates at China-Uganda Friendship Hospital. Now, we know that it's a requirement by Ministry of Health to routinely notify and review perinatal and maternal death in major health facilities in the country. That includes national referral, regional referrals, and the health center force. And we know that reporting is done by M-Track, and that's the work of the records people. Notification and review is usually done by the health workers on the ground. And you need to notify a death within 24 hours and review within 7 days. Now, around 2019, before 2020, actually, we are doing poorly in notification of perinatal death. Reviewing and notification, we had started around 2016, but we're not doing well. So around June 2020, there's a bulletin which is released by MCHN in collaboration with the KCCA, which ranked China-Uganda Friendship Hospital poorly in notification. Actually, we were at, they told us that we are at 0 in terms of notification. But we are doing somehow fairly okay in notification of maternal death and reviews. But perinatal deaths we are not doing well. So following that, with the support from MCHN and FHI 360, we started a project to improve the situation. Those are some of the statistics, the outcomes for the Department of Obstetrics and Gynecology at China-Uganda Friendship Hospital. You can see the antenatal attendance, admissions, cesarean section, total deliveries, cesarean sections, maternal death, and perinatal death. If you calculate like the maternal mortality ratio, crudely you can see like 2021, 2022 year at around 141 per 100,000 deliveries. The perinatal deaths were as follows. So around 2020, like I've mentioned, we were given a rude shock that we are not notifying and we were not reporting. Actually, we're doing some work, but you know, according to the guidelines, if you don't notify and review on the system for Ministry of Health, there's what we call DHIS2. If your information is not delivered there, it's like you have not done much. So, following that, we tried to analyze and find out what was the problem. So we realized that we are just focusing on maternal death reviews and the notification, but we are neglecting perinatal death. And there was irregular, one of the issues we also discovered was the irregular supply of notification and review forms. And the midwives had inadequate knowledge on MPDSR process. They thought it was only the doctors, especially the head of the department, who should be involved in doing that. And there was also lack of interest and a poor response from midwives and other doctors in the department as far as MPDSR was concerned. The review meetings were not regularly being held, and the notifications and the reviews were not being entered into the DHIS2, like I've said. Next. Okay. I think I can. Now, our analysis, we use the fishbone framework to try and identify, because this one is based on just asking questions. Why? Why did this happen? Why is it happening like this? And following that analysis, we realized that as far as the department was concerned, there was knowledge gap on MPDSR, especially on the sides of the midwives and some of the doctors involved. There was no focal person and no proper coordination between the department and records. You know, the records people, for them, they are the ones responsible for reporting on MTRAC. So perinatal death, perinatal deaths were being reported on MTRAC, but they were not being notified and reviewed. So, and then on the other hand, we realized that the midwives had limited knowledge on computer use. There was lack of, actually even the computer was not there. And then also there was the lack of access. DHIS2 is managed by the records people. They don't entrust it with anybody in the hospital. And then there was lack of internet, and of course it was not easy to access printing in the department. Now, that slide shows us where we are. When you look at it in 2020, the beginning of 2020, we are almost at 0 in notification. So following some changes which we did in the department, after acquiring a computer and having some trainings for the midwives and other staffs, the doctors, on how to use the computer and how to access the DHSI2, and also getting a focal person and also organizing meetings regularly, dealing with the MPDSR. We're able to move from 0 notification up to 80%. Sometimes we would go up to 90%. So when you look at that graph, there are some spikes where you see the notification rate, we're almost hitting 200. I'm sure some people wonder why. That was because of the backlogs in some months. And then also you can see those spikes, those drops after the training and making those changes. Again, will still go down. That was the time when we had a lot of COVID, and there were those lockdowns which affected the process. That graph is also talking about the same, but that's around now 2021, 2022. When you look at blue is reporting in MTRAC, and then yellow is the notification of the perinatal death, and then the other gray is about to, it represents reviewing. So when you look at it, actually we have markedly improved in notification and reviewing in comparison to MTRAC, because the MTRAC reports, because we used to be at 0, and sometimes maybe it would be like 20%, but most of the work I even done, we're not entering it in the DHIS2. Now that slide talks about the maternal death reviews. So when you look at it, the report in MTRAC compared to the notification and the reviews, they were fairly okay. Like I told you in the beginning that we are focusing on maternal death mostly. The notification and the reviews were, the focus was on maternal death. And when you look at it, what was in MTRAC and the DHIS, DHIS2 is fair compared to our situation, how it was in as far as perinatal death are concerned. Now, what are some of the recommendations? One of the things we found out is that, one, we need to engage the midwives. Two, we should have a focal person in the department. Three, we need to have some people in the department who can have access on DHIS2. I know DHIS2 is a preserve of records people. They don't allow any other person to go there. They think you are going to do some other things. But when they give access to some people in the department, that's how we manage to improve. So there are also some challenges, of course, though we have improved the notification and the reviews, but we are not fulfilling the guidelines of notifying within 24 hours. And also sometimes we don't review in 7 days, but at least we endeavor to carry out the exercise. So we also have challenges of internet interruptions, incomplete documentations in patients' files, and of course, frequent stockouts of stationery, and of course, workload by the staffs. I would like to acknowledge the midwives and the doctors who are not here, the records department, the MCHN, USAID, which supported this project, because they gave us somebody. Actually, we still work with her, who kept on supporting us, especially in coordinating some of the activities. And of course, KCCA and Minister of Health. Thank you very much.
Yeah, thank you, Dr. Wanyama, for that beautiful presentation on MPDS China-Uganda Hospital. I'd like to invite a call, please. We are time barred. Can you step forward? Okay. Good afternoon. Good afternoon. I'm Dr. Yel Akol. I'm from South Sudan. Currently, I'm doing Ops and Gain Master in Adambrara University in Science and Technology. I'm happy to be here with you today to share with you our finding on our facility-based maternal review at the Ambara Regional Referral Hospital over the 1-year period. Okay. So as we know, in 2017, WHO came up with the maternal mortality ratio of 462. That is in the low income countries, and then in the developed countries, it is around 11 per 100,000. Here in Uganda, it is around 336, and it is important for us to at least know the causes for the maternal mortality ratio, so that this one will help us to at least achieve the Sustainable Development Goal number 3.
So our objective was we review the monthly trends and the causes of maternal mortality ratio at Ambrara Referral Regional Hospital in period for the last financial year 2021 and 2022. So we conducted a review for the trends and then the causes of maternal mortality at the Ambrara, and it was in the last financial year 2021 to 2022. So we review the data. We conducted a review in the data, which was extracted from our maternal death audit, and we went ahead and described the condition, and then the causes, and then the demographic, and then the referral facilities where from where these mothers are coming. So we review this finding, and after that one, we computed the maternal mortality ratio as a ratio of maternal death to the life birth per month. So we got the number of mother who have delivered, and then the number of the mother who have died. So we found in 2021 to 2022, we had 8,018 births. From this 8,018 births, we found 48 mothers who have died. Then these 48 mothers who have died, we have achieved 100% of the audit. So we have done audit for all of them, and we found the maternal mortality ratio from July 2021 to June 2021 to 2022. We found it was 599 per 100,000. So this one, if you can see, it is very high comparing with the recommendation from the WHO for the low economic countries, and then also at the Uganda level, which was 336. So we believe reason for this high maternal mortality ratio, as Professor have indicated in previous session when he was opening the conference. One of the things is the adolescent issue. If you can see, we have more less than 35 mothers from all these 48. Less than 35 mother is around 70. And then also, if you can see, we will get like parity. They are more than less than para 2. And then at the same time, we have the referral. If we can see, we have 80,000 from all these mothers have been referred to Ambrara Referral Regional Hospital. That means more than 75 or more than 80 from this mother are unstable. They came to our facility when they are already unstable. And then if you can see, you will get like a bigger number of the mother have died within 24 hours. And then we have the highest maternal mortality ratio was in June 2021. And this because of the COVID. We know last time we have lost many mothers because of the COVID, in addition to other causes of maternal death. And then in December, we believe in December, we know in December, and then the first the January, always health facility, the workforce is like reducing, and then people are busy with the Christmas and so the referral will be more, and then also patient accessing the facilities will be some challenging. Then we had less maternal mortality ratio was in March 2022. Now the causes, as Professor have put it, nothing have changed. Here in Ambrara, we still have obstetric hemorrhage is the leading cause of maternal mortality. And then others will come in, like the puerperium sepsis and then the abortion, but the leading cause is still there. So we concluded our maternal mortality ratio is high in Abrara Referral Regional Hospital, and then the cause is the bleeding. So our mothers are still bleeding. And this one, I think we need more effort to be put. We know the government is doing its part, and then all the health workers and the health facilities are doing their part, but still we are losing mother. We have to do more. We also recommend one of the things is strengthening the support supervision for the health facilities. So this one will help them to identify those mothers with the risk assessment, with the risk and then the obstetric complication. And this one will encourage them to refer this mother at the acceptable time, and then intervention can be given to them. I would like to acknowledge our head of the Department for Obstetric and Gynecology, Dr. Musa Kenda, and my team for the monthly report. Thank you.
Yeah, thank you, Dr. Paul. That was the perspective from the regional referral hospitals. But like you had, it's a requirement also for the health center for us to do MPDSR. And I did see the flimsy causes, lack of sutures, blood, and those other consumables in your report, like Professor Weiss has said. So maybe we need to audit your. But allow me, without wasting time again, to invite Sister Ariko Annette to give us the perspective of the Health Center 4, that is Anyeke Health Center 4 from Oyam District, to talk to us about how to strengthen MPDSR to improve quality of care. Thank you.
Thank you very much. Good afternoon, everyone. My name is Annette Ariko. I am a midwife by profession. I work with Doctors with Africa, Kwam Oyam, as a maternal neonatal health officer. I'm pleased to present to you an abstract titled Strengthening Maternal and Perinatal Death Surveillance Response that Improves Quality of Care as a case study of Anyeke Health Center 4 in Oyam District. As you see, those are the affiliations and the team people that we worked with. Yes, our background is, as Uganda is committed to ending preventable and maternal perinatal death mortality, we realized that in Oyam, especially Anyeke Health Center 4, in financial year In financial year 2019-2020, we reported a perinatal death in Anyeke Health Center 4 that had increased from 27 to 35%. And also our neonatal death alone had increased from 8 to 11 compared to the previous financial year. Similarly, we noticed that our reporting and review of this death had actually declined from 93% to 69%. That was really very unacceptable. So we had to intervene. When we intervened, what were our interventions? We sat as a team and we had to brainstorm and find where the problem was. We realized the problem was the NPDSR committee could not sit frequently to review this death. We had inadequate meetings to review the death. And the root cause of the poor performance was because of the inadequate meetings that were really so irregular to handle these death reviews. So then, from these meetings, we came up with action points. Our interventions were, we had to elect a new MPDSR focal person whose role there then was to send weekly reminders through the text messages on a weekly basis, daily basis, and inform the team members to assemble on a weekly basis to do the reviews. Having done that, we noticed that, okay, thank you so much for that. Then also we noticed that we had to invite our MPDSR committee members to engage also the DHT members. And so we had to orient them on the MPDSR roles that they needed to carry out. And we built their capacity to carry out and conduct the quality death audits, meaning we built their capacity on how to use the perinatal death review notification tools. We built their capacity on how to fill them. Actually, when we provided them with those tools. And then after that, we also made sure that we sit weekly to review the progress of how we are doing, and then review the death if any of them occurred. And then on a monthly basis, we had to make sure that we review both in the registers and also in the DHA system to make sure that there are no discrepancies, both in the registers into the DHA system. And then also we implemented all the action points that came up from the death reviews, and those included setting up a neonatal care unit, which we really did, and is doing wonders currently with a bed capacity of 10 beds, and we have about 30 admissions per month currently. We are still a baby, 6 months down the road. And then we made sure that we availed oxygen in the ambulance to facilitate referral of the critical cases so that we don't lose out any mother or any baby on transit who needed actual oxygen. And then to make sure that also that the mother and the baby arrived very well, we made sure that we facilitated, supported a midwife to move in an ambulance, midwife aboard the ambulance, to make sure that they move with the mother or the baby, giving them all the supportive care that they required while on transit. And then after doing all that, we got some good results. We noticed that the death reporting and the audit had improved from 69% in 2019-2020, which was our baseline. And then currently, as I speak, we stand at 100% perinatal mortality and the maternal death notification and review. Similarly, our institutional newborn death have also reduced from 11 to 8. And then the fresh stillbirth also have reduced from 16 to 11. And then the maternal death as well have declined, have decreased from 3 to 1 in the same period. When you look at that graph, it actually tells you that in financial 2019, we looked to be performing well. Then the problem came. We intervened in 2019, 2020 is when we intervened, as you see a drop up in there, because that's where our percentage really performance was very poor at 69%. So after intervening, we went on so well, climbing the ladder up to 96%. Up to 100%. Those are the trends of perinatal death audits in the last 4 financial years. And then the status of the maternal death audits. When you look at financial 2018-2019, we had a problem, meaning we had data discrepancies. We were not reporting well. You can imagine we had 1 death reported, but we had 2 deaths that were actually notified and reviewed. That only showed that we had issues, gaps in both data errors, data entry, data capture. So we worked together with the team as a committee, the HMS focal person and all MPDSR focal persons and the committee. We cleaned up and then we intervened, started tracking all our data monthly, weekly. And then after that, we realized that if we reported 1 death, it should be 1 death appearing and should be 1 notified. So as I speak from now, we have had a good progress. We are reporting and notifying. Our notification is currently at 100%. As I speak currently, no errors, no discrepancies. The trends in institutional perinatal death. Our newborn death rate, as you look at financial 2019-2020, 2018-2019, that is where we had a problem. Newborn death were at 11. When we intervened, we had a drop up to 4, which was really very exciting. However, by then we didn't have a neonatal care unit. So that means we kept referring our babies out. Now, after we started implementing our MPDS action points, we set up a neonatal unit in 2021, 2022. Then, of course, that's why you're seeing there's a little increase up to 8%. Why? We are trying to own our death. We no longer want to refer out because now we are a referral site in the Northern Health Sub-District. And that's why we're owning our death. As you see, a little bit of our increase of the newborn death, but at least there's a better change from 11 to 8. However, intrapartum care also improved. And that's why you see the first stillbirth have reduced from 16 to 11, because among the action points to implement was improve on intrapartum care using correctly the pathograph. And that's why you're having at least better results of the first stillbirth coming lower. And then, of course, when you look at the masseted stillbirth, they seem high because they claim that sometimes you don't have control of these mothers. OYAM is a very unique district. We have 30 health units and about 14 health centers to all conducting deliveries. So you realize that mothers come late from the communities. We really have very poor, bad infrastructure. So by the time the mothers make decisions to come to us for antenatal care, most of them come with or without a fetal heart. And so we have a masseted stillbirth. And then of course, also we have a higher prevalence of malaria in the district. And so most of the mothers come by the time they interface with us in antenatal, they are already having malaria and almost no fetal heart. But we're trying all we can. We hope by the next financial year, we'll have covered everything about masseted stillbirth. What am I trying to say here? With good leadership, we work together with the district leadership. Engaging the DHT into the MPDSR committee was a very good step for us to implement. We couldn't have implemented alone. And then also engaging the administration of the hospital and Nyeke Center for together as a team. They provided us good leadership, good guidance, and they strengthened the maternal perinatal death surveillance response. And as such, we had improvement in the quality of care because we were able to implement most of the action points that you see that brought up all those changes that you see. I would like to acknowledge the staff of Nyeke Center for OYAM District Local Government, Minister of Health for always being there. Bruno, I'm always disturbing Bruno every week. Bruno this, Bruno that. But at least thanks to that, we are up where we are. And then, of course, our funders for Doctors with Africa, that is Fondation Assistance International, and then the very implementing partner, Doctors with Africa, Kwam, OYAM, Kwam Uganda. Thank you so very much.
Yeah, thank you very much, Annette. She's highlighted the importance of leadership in strengthening MPDSR in our facilities. And I would not like to add on her message. So thank you for keeping time. I would like to invite the next speaker, Marlene Wilcox, to speak to us about determinants of behaviors influencing implementation of maternal and perinatal death surveillance and response in low and middle income countries, a systematic review of qualitative studies. You're welcome.
All right, thank you very much for giving me the opportunity to present this systematic review on behalf of a whole team of researchers. So my name is Merlin Wilcox. I'm a family physician and a clinical lecturer at the University of Southampton, and I've been collaborating with the team in Umbrara for some time. So the background to this is that the majority, 85% of low middle income countries have a national policy to review all maternal deaths, like Uganda, but fewer than half are implementing MPDSR as per the WHO guidelines. We did a Cochrane review, which found one randomized controlled trial showing that in trial conditions, maternal death reviews reduce inpatient maternal mortality by 35%, which is an amazing figure. That's great. But we also know that in the real world, that impact is not always achieved. So, for example, one survey in Nigeria, Rwanda, Tanzania, and Zimbabwe found that less than 50% of health facilities could provide evidence of any changes resulting from MPDSR. So the aim of this review was to understand the key behavioral determinants of MPDSR implementation and to plan an intervention to improve implementation of MPDSR in low and middle income countries. So our specific research questions what works for whom and where, a realist evaluation, and what factors affect the behavior of actors involved in implementing MPDSR. So we did a search of 7 databases up till June this year, looking for qualitative studies on maternal or perinatal death reviews. And there were 2 reviewers involved in screening the titles, selecting the articles, and we used the CASP tool for critical appraisal. And then we did an analysis in NVivo using coding based on a realist approach, looking for context, mechanisms, and outcomes, and also on a behavioral approach, looking for capabilities, opportunities, and motivation. So after a comprehensive search, we found 59 studies that met the inclusion criteria. Those studies included over 1,800 participants from 30 countries. The most numerous were in Malawi, and you can see the others there. So I'm sure this cycle is not new to you. So in places where MPDSR is working, one of the mechanisms is through recommending achievable actions, which are then implemented, but that's not the only mechanism. So obviously, hopefully that leads to an impact, reducing mortality, improving quality of care. And then if that's fed back, that provides positive motivation for people to continue. But there are other ways in which it works. So the fact of collecting information regularly and doing the review increases vigilance of health workers. So they know that their actions are going to be reviewed, audited. So that in itself leads them to change their behavior and implement changes, improve the quality of care. Also, the review leads to direct learning. If it's a participatory meeting where people are able to learn from the process, and that also leads directly to people improving their quality of care. Of course, underlying this is a learning environment which is confidential, anonymous, blame-free, separate from disciplinary action. And the legal protection helps with that. And obviously, as we've already heard, good leadership underlies all of this, providing sufficient resources for implementing changes, training, good working relationships, and understanding the objectives and the guidance. So this is the ideal situation. But unfortunately, in many places, they reported a dysfunctional, vicious cycle of underreporting, inadequate data, inadequate review, inadequate recommendations, non-implementation, no follow-up. And this led to no impact, or in certain cases actually led to negative effects like fear of blame culture leading to staff shortages and inappropriate referrals to avoid blame. And people becoming demotivated and the process stops. It's not sustainable. And sometimes the lack of impact led to reduced resources. Funders reduced resources when they saw there was no impact. And that again impacted on implementation. Poor leadership underlay a lot of this. Poor preparation, poor working relationships, lack of training, people don't understand why they're doing it, and a poor record keeping. But also the blame culture underlies a lot of all these problems. The fear of blame really led to almost all of these steps, blame shifting and so on. So the key take-home messages are that it's really important to ensure the necessary conditions are in place before trying to implement MPDSR. If there's a blame culture, it may do more harm than good. Direct learning from the reviews is an important mechanism. It's not just implementing recommendations. And the monitoring needs to include direct learning and the adverse effects. So we need a toolbox of strategies to improve implementation. So now looking at a behavioral approach, behavioral science approach, looking at capability, motivation, and opportunity. This is the COM-B model of behavior change. We identified a number of capabilities at every level, ranging from the community to all health workers, to the MPDSR committee members, the leaders of those committees, and the district leaders. Each level requires extra skills in order to play their role in the process. There are a number of important opportunities for implementing MPDSR. The most important is really having the blame-free environment, separating it from litigation and disciplinary action that helps people to participate freely and openly and learn from the process. And of course, it's important to have the adequate resources to implement the recommendations, good working relationships, and people being aware of the recommendations. So often they're not actually disseminated to those people who need to know about them. And then lastly, in terms of motivation, this is split into automatic, things you don't think about. So that's when it's part of your role, when it's institutionalized and embedded in the system. That's a really important way of people just doing it as part of their normal job. But in terms of reflective motivation, very often people's beliefs about their capabilities, believing that they can make a difference is really important and leads to implementing positive changes. Believes that there will be positive consequences. The question of incentives was discussed a lot. A lot of health workers wanted incentives to take part in the meetings, but the only examples in which this happened was financed by external donors, and those donors usually pull out after some time, and that then led to demotivation, which was almost worse than it was before. So key actions to address the blame culture would include legal protection, so legal instruments to prevent use of MPDSR in litigation or disciplinary actions, separating it from disciplinary procedures, enforcing confidentiality, and sometimes rebranding it if a previous system has been associated with fear of blame. So from this, we came up with these components that should be part probably of a complex intervention to improve implementation of MPDSR, starting with stakeholder engagement in implementation research to understand what are the issues locally, then interventions to reduce the fear of blame, optimizing tools to improve data quality, mobilizing resources for implementation, training and institutionalization, so training everyone, not just one or two people, and involving the communities as well. And so for future research, these components need to be co-developed with the implementers. They need to be piloted and optimized to develop a toolkit which can be adapted for different settings. And also we need better indicators for monitoring the implementation and measuring impact and to evaluate its cost effectiveness. So your feedback on these ideas is welcome, and AOGU and all of you are welcome to collaborate in this endeavor. Thank you very much.
Thank you, Dr. Moro. Sure, you receive feedback as we receive questions after this session. In 5 to 10, we have numbers of maternal and prenatal deaths occur in our cities, of which where we are seated is part. And we'd like to hear how enhancing MPDSR at facilities within cities, for instance, a very busy tertiary hospital in Kampala, like Mulago, we want to look at achievements, challenges, legal aspects, and lessons learned. I welcome Dr. Emeka Namagembe to talk to us about MPDSR in a business center. Okay. Yeah, can we all stand up for a few minutes? 1 minute, stand up, stand up. Stretch a bit, hands up, down, turn around, sit down. Thank you.
Good afternoon, colleagues. Just to share with you the work that I'm doing. Fine. That is work that I'm doing because I'm putting on the heart of a student, looking at strengthening maternal death awareness and response at a national referral setting. Those are my supervisors and a number of co-authors. That is our outline. Just basically that's what we've been talking about since morning. The burden is still global. and recognized, but it seems I may need to shift to the other side or get closer here. Internationally, we are targeting Sustainable Development Goal by 2030, Sustainable Development Goal number 3, to reduce maternal mortality ratio by at least 70 per 100,000 live births. Nationally, at least by 2030, all countries are expected to have at least less than 140 per 100,000 live births. And in Uganda, that figure has commonly been talked about since 2016. And the issue is that maternal day surveillance and response, and even confidential inquiry, is a strategy that has worked elsewhere. What is happening in our setting cannot work here. Just reminding ourselves about the MPD cycle. I'll not go into details because others have talked about it. But the issue that in our country, that figure losing equivalent to a taxi collapsing, about 14-seater of women dying every day, and apparently in our national referral hospital, where we lose more than 100 mothers per annum, why have these women continue to die from conditions that are known? Those are the specific objectives related to work that I'm doing for this study. We're trying to do a before and after study, trying to understand what was happening during the period of 2016 to 2018, a period of 3 years, to look at the implementation of the MDSR principles, and then later on we wanted to explore the barriers. We went on to explore the barriers and facilitators, and even discuss priority interventions. And again, later on, we went on to evaluate the effect of training in MDSR leadership and stakeholder engagement to see what happens regarding performance. In the same study, number 1, that one we looked at a retrospective study. For that data, we 300 out of the 401 deaths that were identified in the register, 350 qualified for this study. And over that period, 74,780 live births occurred. And we looked at that data, and apparently what we noted is that of the 450, we had only managed to review 115. That gave us a proportion reviewed of 33%. But even those who were reviewed were not reviewed in time. But we still went ahead to look at even the ones who were not reviewed and compare those with those who had been reviewed. And what we noted that women are dying young, which is common among most of the developing countries. And then we noted that there was no significant difference when we compared those who had been reviewed and those who had not been reviewed, which means that if we emphasize a lot of response, chances are high that we'll deal with a lot of preventing significant mortality. When we look at the causes of maternal death, the data agrees with what is found nationally, where obstetric hemorrhage is the top most cause, hypertensive disorders followed by puerperal sepsis, and of course not forgetting the other causes of mortality related to anesthesia. But what comes out predominantly is that during that time, the issues related to reviews were still on the low side when we looked at that retrospective data. And then when we explored issues related to the delays, our data showed that most of the women who died had suffered delayed at the place where they died from at the national referral, almost that proportion. And we noted that even delays at the family level, about 37, and we noted delays at other places of health care, which are still high, which means that by the time the person died from the health facility, some of them had already suffered other delays. And when we noted that of the death, almost 60% had suffered more than one delay. Conclusion from that retrospective data was that the proportion of the death reviewed was still low, and yet this was the National Referral Hospital and Teaching Facility, which should be a center of excellence. And almost 70% of the deaths were from obstetric hemorrhage, hypertensive disorders, and puerperal sepsis. So the need to really address health system strengthening and to reduce the delays will probably help us to reduce this death. So the fact this work, we've managed to publish this work. Those of you in case later on we managed to create time, And we also looked at even the issue of uterine rupture, which we noted as a major killer among our mothers. After looking at the data in the retrospective data, we went further to find out what are the barriers and facilitators to implementation of MDSR at this national referral facility. And we conducted a epidemiological study with various stakeholders, the internal and external stakeholders. Because of what was coming out from during the qualitative work, we noted that we needed even to involve the lawyers to see what they were saying regarding this aspect of MDSR, since the issue of fear of blame and fear of litigation kept on coming out from the participants. So for the qualitative study, we had the total number of participants, those are their characteristics, and then we noted that the major barriers which were identified, which were reported by the participants, were issues related to the inadequate skills and knowledge. There are issues of heavy workload, issues related to inadequate leadership and governance, and then there are issues of negative attitude, and then the other aspects is that apparently when you went further to explore issues related to, sorry about that, issues related to the facilitators. In this case, they apparently tended to report, no, this is barriers. Barriers I've already mentioned, and these are some of the major aspects we learned from the barriers. The participants proposed that we need to work on implementing the recommendations, and this was observed by both the midwives and the obstetricians and the other teams who participated. But still, they commented that the aspect of negative attitude does appear amongst a number of participants, a number of health workers. We requested them to propose what they thought were facilitators, and these are the aspects they reported. But if we include all, especially including the midwives, because the midwives we felt that they had been left out, and then strengthening the governance issues to ensure that they eliminate the aspects related to blame, and then the issues related to enhancing the incentives. These are some of the facilitators which are the quotes from the facilitators. And then the fact that we had involved the aspect of the lawyers. The lawyers who are identified were people from organizations that regularly participate in issues of maternal health and participated in issues of maternal health litigation before. And some of them were identified snowball, others were working in academic institutions. What we noted that the lawyers felt that this MDSR process is very good, and we are saying that the health workers need to ensure that they follow it up. And they also felt that the issue related to the maternal death review information, apparently they affirmed that this information is not protected. If court is authorized, it can access this information. And yet the health workers had also reported the fear of blame. However, we encourage the health workers to do their part and document properly and utilize the protocols, that it is hard to prove the health worker negligent if they are found to do their part. Then the other aspect they brought out strongly is that we need to conduct regular legal compliance and further regional meetings between the lawyers and health workers to enhance issues related to quality of health care, to mitigate the fears of litigation. And they stressed to us that the fear of the big numbers should not be something that we need to always address. That issue should be addressed by the managers. But for us, we need to do our part. And whichever patient you've touched, do your best. So what we got from this baseline work is that all study participants scored the process as very useful. The barriers at individual level included the issue related to the lack of skills, the negative attitude, and then the issue related to the leadership at facility level, blame, the lack of supplies, the failure to implement recommendations kept on coming up. And at the Ministry of Health level, they felt that issues of funding should be addressed so that all these other aspects, basically looking at the health system building blocks. we propose to have interventions since we had asked the participants to identify priority areas. And most of this really say that the training of health workers should happen for all, and then the issues of the leadership, and also we went on with stakeholder engagement. And this is what happened after a period of 19 months. And we note during that time, a number of aspects occurred regarding the response. Again, following the health system building blocks, there were issues related to capacity building of the workforce, training, there were issues related to increase in funding, that is discussion with the various stakeholder engagement with the Ministry of Health and parliamentarians. And as you see what is listed there for the sake of saving time. Those are just some of the pictorials showing the training, multiple people at various levels, the specialists, the medical officers, basically various levels to ensure that we get on board with the issue of knowledge and skills. And at the end of the 19-month period, we compare the data we received to that occurred at the 3 and the baseline. And apparently there was no difference regarding the characteristics of the mothers, which means that the study population remained the same in our setting, which is expected. And what happened, at least there was significant increase regarding the timeliness of the notification and the timeliness of the review. But we did not hit 100%. We thought that we would be able to hit 100% for the maternal, but this did not happen. However, although I'm reporting just about the mothers for purposes of the focus of research, but the events which were happening were also happening on the side of the perinatal. Just to share with you, a number of events happened during that time of the 19 months. The trainings ended in February 2020. Then the participants started tracking the events which were happening in the institution. The notifications started improving. However, when the issues of COVID came on board, we realized that there was performance was interfered with. And after some time, again, with continued engagement, the quality issues to support quality improvement activities was promoted, and then they picked up. This is where we hit 100% with a notification, but so the performance went on like that. But what we noted that with the first lockdown, the impact was greater. But with the second lockdown, the service providers had been trained and they supporting quality improvement issues, and the partners on board to recognize what was happening at this busy setting supported that quality improvement activity. And so those are some of the quotes later on from the participants. They said that they were owning the process more. A number of them reported that the blame had greatly reduced, but still some reported that occasionally episodes of blame tend to come on board. And we did not only remain in the hospital regarding this kind of things, even in the antenatal, and then going on to the media, trying to involve other people regarding what can we do in that aspects. We're emphasizing them to support the pillars of safe motherhood, because it comes out critically, how can we reduce these days, and even informing them to be aware about this process of maternal death review, so that the first issue that when someone dies, don't take the health worker to police, but how can we find out what happened so that we prevent another death, as of course we console that family. And a number of achievements, the health workforce, there was capacity building, trying to see a number of projects with the partners. Most importantly, the National Referral Hospital used to be ignored in the past, saying that it is complex, but at least there was support. Partners started coming on board and giving feedback to the other facilities. Looking at those various health system building blocks, all of them, but of course it requires funding, because some of the aspects which occurred, like ensuring that the health center floors are functional after giving them feedback, a number of these things have not been sustained throughout the period. And so when it comes to the cause of death, is that the death is still occurring, the burden is still high in our setting, we still need to do a lot more, but predominantly most of these deaths are notified and reviewed in time, but we are still doing a lot more as far as this environment is concerned. So all we are saying that there was significant increase regarding the notification and review, the timeliness, but we still need to do a lot more regarding as far as the response is concerned in order to have impact to reduce maternal mortality in this setting. All those are some of the lessons learned. I will not go through each and every one, but that's where we are. And I would love to acknowledge all those who have supported this cause. And to each and everyone in this house, it's usually a joy to the midwife, the doctor, and all people concerned when you see a mother with a live baby. And thank you.
Thank you. Yeah, thank you very much, Dr. Imelda. For being time, we have 5 minutes. If you have any question within 5 minutes, you should have asked and we should have answered the question. Mine I'd like to hear how what innovative ways you have or you're doing in your facilities to address the issue of the flimsy causes. How have you addressed the issue of not having sutures, not having blood, not having gloves, in prevention of maternal and perinatal death? Okay.
Thank you very much, the presenters. Dr. Waswa Salongo, skilled, advanced skilled birth attendant. Dr. Onyama, Dr. Namagembe, there's an issue that I've captured several times which coming out from your presentations, and this is the issue of attitude. And also I do find this a problem where I work. Punitive things may be taken against you, sanctions, extra work, time consuming, is no benefit to me, whether direct or indirect, and NPDSR reviews are not my job. How have you overcome this issue? What are your recommendations to overcome this issue? Thank you very much.
Good afternoon. Betty Nakavia is my name. Mine goes to Anne. She's not around. But my question was on the increase in the macerated stillbirths that she mentioned. She gave a few markers of antenatal care as the causes. I'm wondering what recommendations came from the death reviews, and if so, have they been followed? Thank you.
I'm Jacqueline Amich, a senior resident, Macquarie University College of Health Science in the Department of Obstetrics and Gynecology. My question goes to Annette. It says these intolerance was seen because of a project that is funding this activity. And you know, projects have a lifespan. After the project has left, what interventions have you put in place to ensure sustainability of the NPDSR committee that has been put in place in the Health Center for? Thank you.
Thank you very much. I'm Dr. Baifa from Gulu Regional Fire Hospital. My question goes to Dr. Namagembe. NPDSR in the National Fire Hospital, the response arm of NPDSR, to what extent has the National Fire Hospital engaged by the firing facilities? Because I have seen this as a response that actually works, where we follow up the referring facility and identify the root cause of the missed opportunity and address them. So to what extent have you gone? Thank you.
So let's just answer those ones and then we break off for lunch. I'll first give the mic to. It depends. So a lot of midwives. Some of them are not seeing each other and the people have been to yourself there. How I handle these midwives. You will find the attitude changing incidentally. So that's how we have managed to change the attitude issues. How you conduct yourselves. If you're going to think you command them as a senior consultant, no. Put yourself in their shoes, lower level, and work as a team. So once they see the benefits, then we will work together. The attitude issue will change. Thank you. Well, what I know is that our senior, Dr. Sarang, is a self-proclaimed midwife now. He has even shown an affidavit that he's a midwife, but he still has challenges. So I think it's beyond that. Maybe you can hear also from Dr. Namarimbe how she's addressing that.
Thank you for the questions. One of the, like what my colleague has said, regarding the aspect of attitude, of course, it's not a one-day event, and there's no single bullet that can address it. But recognizing people and reminding them that they are part of the team, and together we can make a difference regarding this quality of healthcare, have been part of the engagement. And when we are giving feedback of the date and discussing it, and not doing it once, has encouraged a number of people. We can't say that it's 100% change of attitude, but to a certain degree, most people have changed. But again, the arm of the leadership, the strong leadership component, emphasizing the aspect of accountability, but not necessarily blaming, and at times calling such people, talking to them, because it's a continuous process, not done just once, but encouraging accountability that all of us are part of this story has helped to a certain degree. And the aspect of leadership is very critical, where we are taken to account for some of the things, although in an environment that does not necessarily blame. How do we work tapping into the rest of the leadership aspects within the hospital? And then, of course, there's this aspect of no blame within the MPDSR. And some people take us to task that if you don't blame, how are you going to change? But how can that happen? How can we hold people accountable and encourage change, especially utilizing the protocols, but at the same time realize that when you enhance supervision at the various levels, a number of things are likely to change. There was a comment, I think, from the chair, how have we addressed the aspect of shortage of blood supplies? On one of the slides, we put that one of the issues that has happened at the national referral is appreciating that it's a high volume setting and many people are referring to it. And we realized that when they critically analyze the budget for that institution, after engaging with a Ministry of Health team and all people getting involved, because when we trained and encouraged people to notify, it kind of, those deaths were banging the doors and saying, what is happening at the National Referral Hospital? People got concerned. At one stage, one of the colleagues can share, because there are times when they really even involve police to investigate, are these really true deaths? Are they happening? So that means that when we do our part, and they also get concerned to find out what is happening. So it's a continuous process, continuous engagement. Blood supplies are being prioritized for the National Referral Hospital. Quite often we face shortages. You remember the lockdown, the schools were in lockdown for long, but somehow, even sisters in the health workers themselves, because there are times when we don't utilize those blood supplies properly, or you take blood to theater and you don't use it and then you don't return it. So we encourage to account. Challenges do happen, but somehow the national referral is being prioritized in a number of areas. There was even an increase in the budget. The budget increased about 3 times compared to where it was. Although what was increased does not cater 100%, it was increased from to go up to about 60%. It's better than nothing, but still a lot more needs to be done. That's why we are saying that the issues of advocacy to ensure that that national hospital is prioritized are critical. One of the colleagues asked that to what extent have we managed to give feedback to the referring facility? This has happened, is happening. A number of facilities, especially health center falls that are referring to the National Referral Hospital, they've been involved in regular feedback. Even with the COVID-19, when the Zoom component came on board, they've been involved in the discussion and then at times organizing teams, but this has been possible working closely with the partners. But occasionally there will be such questions. Who is answerable to that? What is the National Referral Hospital supposed to do? And who can listen to these people? So working closely with the people, because you can have power and authority. You may have the authority, but without the power. You may be a leader, but without power and no authority. So at times all these need to be on board, because the people you're talking to need to be able to listen and to appreciate what is happening. But that has been done. It's not yet 100%, but we've made calls, at times visiting even places as far as Iganga, Mubende, Entebbe, and at times death occurred, you call a colleague, what happened? Although one of the things we've noted, that's where community engagement is also very important. We've noted situations whereby a particular maybe husband may request, I want to take my wife to the place near to where I work from. But unfortunately, they go there without confirming that maybe the single obstetrician there is available. And they get there and realize that patient in poor shape and the obstetrician is not on board, like it happened on some of the patients who had placenta previa, moved from one place, passing the national referral, going the other side, and later brought back. So we need to continuously engage people and emphasize timely referral and getting closer to the facility once it can offer comprehensive emergency care. So it's not a single bullet, it requires a multi-sectoral approach, and it's not an overnight event, but continuous improvement is the way to go. Thank you.
Yeah, thank you very much, presenters. Unfortunately, we're out of time. I would like to encourage you to continue interfacing with our presenters as we break off for lunch. I know you have so many questions, but we don't have enough time for each of you to ask. So as we break off for lunch, try to engage each one of them on an individual basis, depending on the question that you had. Otherwise, thank you very much, our dear presenters and the listeners. Thank you. Back to the chair.
Thank you so much, Dr. Mugabe Kenneth, for taking us through this session. In the interest of time, apologies where things, especially timekeeping, we're trying a little bit. We are seeing what is going on. In the effort of supporting each other, some of the partners or the teams that procure the stalls, support the conference activities, are going to conduct 2 raffle draws. One of them is going to be conducted now in just 1 or 2 minutes. Allow me to invite this very senior skilled birth attendant to really be able to perform this task. There are 2 that are the lucky winners that will walk away with these hampers. Kindly members, I encourage us to continue visiting the stalls, see what is shared or in trade. So that's also most welcome. Kindly, can you shake a bit and then be fair, transparent? Yes. So the first winner, the stalls are in the corner, the stall on Stars and the Philips Pharmaceutical Company. I am supposed to just hold the box and then you open. Yes. Yes.
Number 055, Saito. Number 055. 055.
Senton of Gertrude. Senton of Gertrude. And then the second one, check it. speak out. Please.
Number 011.
011, can you bring the gift? 011, get the name. Get the name. Can you sister get to come this side? For a moment. Images, please. How is the picture team representatives? Then the second one is 011. Prakash Patel. Prakash. Prakash, come for your hamper. Or shall I pass it on to you? Don't mind. Yes. I know him. I can take it on his behalf. Thank you so much. There's another effort draw after the last session. Thank you so much. Patel Prakash. So thank you, members, for this occasion. And please, members, continue visiting the stalls. We shall break up for lunch, 30 minutes, if we can. 30 minutes, and then return for the sessions. We prayed in the morning for all to go well, plus the meals. Can you members please move? It is silver. The instruction is on your coupons, please. Level 1.
To accelerate efforts. This is according to WHO. But few previous studies exist where midwives lead and are involved in QI. So this project, there were 3 quality improvement components focused on, and these were in line with improving the management of labor. And these the dynamic birth positions, improving the intrapartum support, and also improving perineal support. These are 3 focal areas that we are supposed to do as midwives in managing labor. So the components are based on research and international and national guidelines as decided in collaboration with the midwives and managers and women giving birth at Naguru Hospital. We sat together and agreed on what we thought were our problems. Next, please. Okay, sorry. So the main objective of this initiative was to build capacity for the midwives to take lead in improving quality within maternal and newborn health care. And the QI implementation was the baseline. We had to collect baseline data, which commenced in May 2022. Then there was didactic and clinical trainings for the midwives, ambassadors, and then exploration of change ideas using the PDSS cycle, and ongoing mentorships and peer support. Data sharing, learning sessions, and feedback also were ongoing, and then also involved the departmental managers and administrators to support. So in regard to the dynamic birth positions, these simply are those, they include using the birth chair, standing on all fours, side positions, kneeling positions. And we also understood that these have potential advantages from previous researches. And some of these advantages are increasing space in the pelvis. And all we know is if we get the head to descend, then labor can really, the contractions can be more effective, less likely to need medical interventions like augmenting with oxytocin, and also reducing the Caesar rate, emergency Caesar section. Upright positions, we also saw that shorten the duration of first stage of labor and also provide the woman's comfortability. So with all these advantages, we had to seriously look at what we can do to engage with most of all these other positions other than the routine positions that we've been commonly using. So that is an example. She's seated on a chair. She had her delivery at Naguru. That other one is a midwife in the labor ward. So you can see the joy of the birth chair. Then the other area of focus is the intrapartum support. And in this support, this includes the emotional support during labor, the physical support and comfort measures, and then information, giving information and advice to our women during the first stage of labor. And of course, with all this support, we realized that we had gaps. That's why we say, let us try out these things. Let us give this support to the women. And researchers have shown potential advantages like higher frequency of spontaneous vaginal deliveries. And then somewhat a shorter birth. And then positive birth experiences, less babies with low AOGU score. These are examples of the intrapartum support. For example, the rebozo. Rebozo is a lesu. Rebozo is a Mexican word, but with just the lesu, making sure you maintain this woman in mobility and upright is very, very useful. So, and then the lung, where the woman continues to either climb stairs or lifts her leg. All those are the supportive interventions that we've been engaging with our women. More examples: lying on the side, standing on the all fours, leaning forward. This other one is seated on a bath chair, a stool. In a way, it widens the pelvis. And remember, all we need is descent, effective contractions, and eventually good and shorter time of labor and birth. That's the birth stool. We have those tools at the labor ward. And actually, we acknowledge, our doctors have acknowledged that this is a miracle stool. The woman sits on it, her pelvis widens, baby just drops down, and you get it out. So we have quite a number of them. They're like 4 in the labor ward. That is an example of the woman who gave birth. So the other focus area was the perineal protection. And this includes having good communication with the woman during labor, during birth, listening to the woman's urge to push. We used to say, push, push, push. We've moved away from all that. You have to make sure before you tell the woman to push, you have really seen that she has the urge to push. They look simple, but they're very, very effective. And then the slow birth of the baby's head. So on a bath chair, you realize that the baby's head will just get out without any much pushing. So, and all these other positions like we talked about. So the slow bath is another very good thing in regard to perineal protection, perineal support with the two hands as seen in that picture, maintaining flexion, and also some support at the perineum, avoiding routine episiotomies as recommended by WHO, and applying warm perineal compress. We have a kettle in the labor ward with small buckets. We boil water and also have the gauze pads. Just warming that muscle relaxes it and minimizes tears. And the woman actually says, I really feel good, less pain. So we've engaged with all these and we have seen such great advantages, less tears and decreased pain and reduced workload. So how? The process behind the midwives. Remember, we are building capacities for the midwives to continue with all these interventions as part and parcel of their routine. So data was collected, data will be collected in 3 and 6 months after the active period of the QI. There has been an active period for this quality improvement with the researcher, Johanna. She's a PhD student from Sweden. But we plan to continue collecting data. Even when the research has withdrawn, we just want to see that our capacity has been built to continue carrying out all these interventions in care during labor. And then we plan to continuously engage the ambassadors to build their capacity more, to be the examples, to share knowledge, and to continue mentoring all their peers. We have a total of 7 ambassadors, and they have that, their roles are very clear. They have to do the ambassadorial work. Then staffs and leaders to benefit from this initiative. And then we also want to move to a level where women request for the kind of care they desire. And then continuing training antenatal staffs at health facilities. Oh, time is up. So thank you. We plan to scale up. Just a minute to summarize, please. I'm sorry. We plan to scale up to other facilities and also to see that all these initiatives continue. To thank our head of department, Dr. Wanyama. He has been very, very supportive, and the hospital director and all the midwife ambassadors and all the midwives in general, because all of them are now picked up, and we even see all this well documented in the patient's file. Thank you.
Thank you, Sarah, for that exciting presentation. I think as a team, you'll need to visit our other facilities so that we can also, so that our clients can also gain from this beautiful experience. Next up is Dr. Kazibo Lawrence, who is going to give us an update on pain management.
Thank you very much, Dr. Susan Ataire. Good afternoon, members, delegates. I'm Kazibo Lawrence, an obstetrician gynecologist and a clinical head at Kanope National Hospital. Allow me share with us for all the delegates here, SHOs, nurses, midwives, and the specialists on an aspect of pain management with reference to step 1, WHO analgesic ladder. So I'll take us through the presentation outline. Yes, as defined by the International Association of, thank you, International Association of Study of Pain, the 1979 definition vis-a-vis what we have of late, treatment, pain and pain relieving treatment definitions, type of pain, the pathways, WHO analgesic ladder,
and then introduction of one of the molecules, two of the molecules that are, some of them are being made in Uganda. By definition, so pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage and described in terms as such damage. So the current one divided into the current types are nociceptive pain, which mainly relates to tissue damage, whereas neuropathic pain relates to somatosensory system damage or nerve damage. Pain relieving treatment are measures that alleviate or soothe pain in order to improve function and quality of life. The differentiating between these two, like I earlier said, as the whole body interacts with the environment, these are some of the damages that are like the tissue that are likely to cause tissue damage. That's to do with chemicals, the extremes of temperatures, the heat, hot or cold, physical force, and then mainly the external injuries commonly cause a feeling of sharp pains, aching and throbbing. There's also different types, like in acute, depending on the time frame that the pain had stood. Neuropathic pain, like I said, it's mainly nerve damage, and it's characterized by shooting or burning types of pain, including numbness, tingling, and phantom limb syndrome. Main causes of this problem, neuropathic pain, conditions like alcoholism, suffering from diabetes, HIV, multiple sclerosis, vitaminosis, chemotherapy, therapeutic agents, and the radiotherapy side effects. To further explain the path of pain, how we perceive pain in the brain, looking on the left-hand side of our screen, we can see that from bottom up, on the left side, we have trauma or inflammation processes or infestations per se that are registered by the nociceptors. And then we have the peripheral sensation, which again is conveyed to the spinal cord, and finally to the centers in the brain that have been identified as those that register the pain. In the spinal cord, the hypothalamus, and the cortex. The other side of the nerve injury, this is registered generation of pathological ectopic discharge, which also goes along the spinal cord and then to the thalamocortical system, and then the pain is registered. The attempt on the right side was to show us the different processes, how pain is generated from, for example, if we take on the part of inflammation, if it's infective, the different pathways, how the arachidonic acid and the eicosanoids are released, and then the enzymes involved, and then the tissue damage and what is picked up by the sensory system, and then finally to the pain centers in the brain. That was just a comparison, and I'll skip that. The different facilities we are coming from has some form of tools in helping to assess pain. That is the visual analog scale and the pain analog scale. On the left, we can see that if we have people who are not well educated, it may not be very easy for someone to put or quantify the pain using this scale. Whereas the visual bit, it may also be a little difficult. So there are colleagues who have actually translated this kind of scale into this where a client in front of us can move on the scale on this number line, where the magnitude of the pain they're feeling. Whereas the lower part shows the images there to describe how they feel with those visuals. Another set of scales, I downloaded these on the internet, so I don't have rights on them, but we use these in most of our institutions to assess pain. And if you look at this, the correlation between the visual and verbal scale, 1 to 3 is mild pain, whereas 4 to 6 is moderate, and 7 to 10 severe pain. How do we deal with these problems? Dealing with pain, alleviation, nociceptive pain, we ask us to deal with the underlying condition or awaiting the injury to heal, okay? Or finding the right combination of pain management strategy. One is a physical therapy. For example, where we have fractures, we may need to stabilize, these limbs. We also need to apply traction forces to retrieve or relieve the contracted muscles. We may also have recommendations to have these clients procure over-the-counter drugs which are acceptable, like paracetamol or acetaminophen and the NSAIDs. Prescription medicines, which are really done by us, the clinicians, and then alternative therapies, and then surgeries to treat underlying injuries, like you've seen us doing endometriosis. On the right is an image introducing the WHO modified analgesic ladder, where number 1, from the pains, the scales that we've used, we rate the kind of pain on the ladder and then the kind of medicines we are to give these clients. From 1, mild pain, 2, moderate to mild to moderate, 3, moderate to severe pain, and then the 4th tier they are adding, which is severe to very severe pain. These attempts at explaining a little more about the WHO scale and the medicines that are utilized in each scale. And if you look at 1 on the extreme left, the non-opiates drugs that are administered in step 1, and the NSAIDs. Step 2 are weak opiates, and that's codeine and tramadol. Step 3, strong opioids like morphine, fentanyl, and then lastly, the adjuvants that we mainly administer for these patients. We have some anticonvulsants and the corticosteroids and antidepressants. So picking on step 1, where paracetamol belongs, the mechanism of action, like I said, paracetamol is mainly centrally acting. Through those measures, it has an analgesic role and also an antipyretic role. So that is what this slide is all about. When would you, if you're suffering from pain, what do you need to take to quickly alleviate the pain? So we have different formulations where the molecule must be delivered into the system where it works, where all the receptors, where it is working. And there are these different formulations. So allow us in this conference to share in a effervescent form. And we shall tell us why we are looking at this particular molecule. So we know that the advantages of the technologies, first of all, the technology was developed as early as the 1930s by that gentleman. There are uncoated tablets with medicinal agents, but with also acid substances like carbonates and hydrogen carbonates. They react rapidly in presence of water to release the carbon dioxide and the water, and then allow the molecule to disseminate in, disperse in water, and then swallowed, enable absorption, and then quickly getting to where they should be working. This slide shows an assessment of patients that are presented with pain. They're comparing between the effervescent type, those that took effervescence, vis-a-vis those that took the ordinary paracetamol tablet. And we are seeing the serum levels of those that swallowed paracetamol effervescence, the levels really on the higher side. In 50% of
those that had followed the effervescent variety, 50% levels in serum were registered as compared to their counterparts, about 15% of them. And in 30 minutes, the amount had risen that high. Chairperson is on my neck, I'll be 2 more minutes. Thank you. How did we handle with relieving pain? In 12 of those that had taken effervescent variety of paracetamol, close to 95% of them were reporting the symptoms subsiding, as compared to only 5% who are taken ordinary paracetamol. It is easy to formulate, it acts faster, put in water, and then dissolve. The formulations are two. We have 500 milligrams and the 1 gram kind of dosing that is given in water to these clients. We have the under 12 and the adults tablet formulations that can help alleviate pain in the people who complain of mild to moderate variety, as I stated on the WHO analgesic ladder. Lastly, let me talk about the Cipladon Plus. For when it is that kind of pain, this is called in, the ingredients are in there. I know we shall continue interacting at the stall. Members, please visit the stall and see what more further information about this method. I thank you. This is done in produced in Uganda by Cipra Group, and it's now available on the market, licensed by NDA and all the other relevant authorities. So members, thank you for listening and good deliberation.
Thank you, Dr. Kaziwe. I would encourage the other presenters to kindly keep time. We have an AGM in the evening, and I have some vested interests, so I would want all of you to still be around. So next up is Dr. Pebalo Francis. Pebalo, as he comes to the podium, is an obstetrician and gynecologist. He's a lecturer at Gulu University and the acting head of department, reproductive health, Gulu University. He's the founder and executive director of Gulu University Section Reproductive Health Resource Center. And they do a number of things, including research, capacity building, and they also give grants. So for those who are interested in getting grants, and he's also an entrepreneur. He's the director of Good Hope Medical Center, and he's the father of 4 boys. Thank you.
I like the 4 boys. Can I? Thank you. Thank you so much for this kind introduction. Surprising that. So I want to have a small presentation about reproductive health simulation training, a feasibility and self-reported efficacy in Gulu that we did. There is need for reproductive health simulation. Why? Because most of the emergencies reproductive health conditions actually causes significant maternal and neonatal morbidity and mortality. And these emergencies are unpredictable. They create a kind of ethical dilemma. And most of the times when they come when most of us are not prepared. And sometimes if us who are in training, we have to train people on these kind of conditions, it becomes hard. An example is when you want to train someone on how you can conduct a shoulder dystocia. When you get a real shoulder dystocia, it's really very hard to train someone on that. So the only way to do that probably is to have a simulation. The probability that this adverse outcome, when this reproductive health emergency occurs, the probability that the adverse outcome will occur depends partly on the competencies. That means that it is the knowledge of the providers, depends on the skills that they have, and the decision-making capacity or capability, and then the attitude that they have. And also, it depends partly on the environment, that you look at the hospital settings. We look at the equipments that are there, the supplies, the leaderships that are there, probably the technology and the medications. So it depends on that. So we thought we look at the competency. Probably that's something that we can do as in the training institution. We looked at simulation-based training as something that can actually enhance clinical competencies. It can enhance the skills, the decision-making capacity. It can also improve team communication between the provider and the patient, the provider and another providers, and that would actually improve on the outcome of obstetric emergency. The objective of this was to assess the efficacy of simulation-based training on major reproductive health emergencies and procedures, on the competencies of fifth-year medical students at Gulu University, and also the interns, both the intern nurses, intern midwife, and intern doctors in the two teaching hospitals of Gulu University. That's Lacho Hospital and Gulu Regional Referral Hospital. What we did was that we got some small funding that was able to help us establish, to improve on pre-service education. And this funding helped us to establish a simulation laboratory that had an option of audiovisual recording. And to make us be able to deliver this content throughout in a very uniform way, we were able to actually produce what we call a context-based mini curriculum for this simulation training. And this curriculum is actually presented to faculty board, faculty of medicine, and it was actually approved. And this curriculum is a 4-day curriculum that is used for training the students and training the interns as well. What happened is that to have all of us be able to have uniform content given to our trainees, we're able to have a training of trainers. And this training of trainers was done by the Association of Obs and Gyn, and we are proud of that. Gulu University partnering with our association to be able to train these people. And we were able to train the specialists, the nurses, the medical officers, and the midwives in Gulu University and the teaching of hospitals. For this, we are reporting a case of where we are able to look at the outcome of 40 medical students, 5th year, and 21 interns that were trained for 4 days. What we were able to do was to see if it works. We're able to do a pre and post test, which is consisting of 43 MCQ items. We're able to do a paired test to look at the difference between the mean score of the pre and post test to have that done. So we were able to have that, and then the mini curriculum was approved, and then that was the training by the team of AOGU that were in Gulu, and this is what we're able to do. Of course, the 43 tests were done. Paired test was done to look at significant, and this is one of the pictures that shows what we're able to do. We're able to use most of the time local material as simulators for our students. So this is the results that shows that overall, for both the interns and the medical students, there was actually a significant difference in the score, mean score between the pre-test and the post-test. And you realize that the students were able to score even more than the interns that was there. And among the interns, you're able to see that the intern midwives, the intern nurses were able to score more than most of the intern midwives and the doctors in this pre-test. And this is actually one of the plot that we shows that for all of them, there was a significant levels of difference in the score with a p-value of 0.01. And this is among the students. Of course, one student probably did not change because I think the score was the same. between the pre and post-test. This is the difference between the interns. We realized that the intern midwife were able to have a significant different levels of score compared to all of them in the pre and the post-test. What did these people say? What did the trainees say about this training? One is that the students were able to say that the design was clear for them and they were able to appreciate that it's very clear. In 78% of among the students, the interns also appreciated that it had very clear objective. They were able to actually appreciate the trainers that were professional and confident in training, as well as among the interns. They realized that most of the time it was practicum, and then as well as among the interns. Of course, some of them suggested, up to 80% of them suggested that the time was not enough. And this actually increased among the interns, and they thought the time was not enough. The 4 days training was not enough, and they were able actually to apply. They were willing to apply in the subsequent ward practice. So in conclusion, we realized that this was actually effective in knowledge transfer. Of course, we're not able to do a knowledge retention that shows that probably they're able to retain knowledge for a longer period of time. And this knowledge transfer was good for the undergraduate students, the 5th years medical students, and then the interns. And this we were able to do it at the beginning of the rotation. So as the interns are rotating in OBS-GYN ward, both in Lacho Hospital and Gulu Hospital, we will do our training. And as well as the students are joining our rotation in the Department of Reproductive Health, we do that training at that point. And we thought maybe in future we'd be able to have it enrolled up to 3rd year so that by the time they come, it's much better. Thank you. Thank you so much.
Thank you, Dr. Pebalo. I think what you're doing goes a long way into standardizing practice, having these trainees actually going through competency-based training before they do their clerkship. Next up is Dr. Antuyo, another obstetrician and gynecologist who is very passionate about simulation training. As he comes to the podium, he's a consultant MFM specialist at Mulago Specialized Women and Youth Hospital, and is currently doing his PhD, and is going to share with us a setup of medical simulation training, 1 room versus 2 room at Kawempe National Referral Hospital. As he presents, is Dr. Kagawa with us? If he is, kindly come to the front.
Thank you, Dr. Atuhaire. Good afternoon. Go back the first slide. Go back the first, okay. No. So that is my topic, and those are my supervisors. I acknowledge Professor Nachimoli, Professor Gibb, and the Beatrice from Netherlands. As you know, good things don't come easily. I would like to recognize people who have nurtured me in this profession. The first one is Professor Kaye, you may not remember. He helped me first time to do the research undergraduate. Then there is Dr. Imelda Namagembe, a good mentor. So what I'm doing is that Professor Vyaruhanga, a very good mentor and deals with governance issues. And then there is Salongo, midwife. So this work I'm going to present may not be part of my PhD, but because we had to do it, I have to present it as an innovation. We know that the background is that we know that delivery in facilities increased from about 42 to about 78 mothers delivering health facilities. But this one did not translate directly to the reduction of maternal mortality rate. So people questioned what was the problem. So this work came to address delay 3 and mainly in the skills, delay of receiving appropriate care when you reach health facility. That's the outline. The background, I have 4 eyes, but I may need to move a bit near. We know that simulation training has been occurring in around Mulago College, Makerere University and Makerere and Mulago from around 2014. And it was mainly the SHO residents going through this training. And we know that also maternal mortality has been declining all over the world, but in Africa, did not translate, the reduction in low and middle income countries is low. We have the Ugandan figure. I know Professor Weiss presented WHO estimate, but we take the UDHS, which is 336 per 100,000. And neonatal mortality has stagnated at 27 for the last 3 decades. So it needed, despite the training, so it needed an innovative way of coming up with training health workers in skills. And this one is through simulation. Simulation is very good in that you use the models to build the skills before the health provider goes to the ward. And this one makes the patient safe. And also it has been was observed that there were many health training institutions and there were many students. At times, in some of them, the students were more than the patients. So it needed that we have to use some of these simulation models to do that. Those are some of the statistics. They are a bit old, but we are using UDHS. You know the maternal mortality, the contraceptive prevalence. I know there is what was Professor provided, but we are still at that. Yeah, thank you. Yes, I can thank you very much. Contraceptive prevalence has been improving for all contraceptives for that. And the neonatal mortality, maternal mortality, we know that the neonatal mortality has stagnated over that for the last 3 decades. So we know that medical simulation was conducted in 2 rooms previously. Yes. Previously, we used 2 rooms to conduct this training. One is the scenario, and then the other one is the debriefing. And that was what we're doing. But because I was doing this study in Kawempe, and yet I worked in Mulago Specialized Women Hospital, the reason was by that time we didn't have enough patients. So at Mulago, at Kawempe National Referral Hospital, we provided 1 room, and yet the setting is for 2 rooms. So we had to conduct this training. So we had to do a lot of modification, reducing the audio video set to recording only during the debriefing. I know most of the midwives have gone through this training. We have the recording and the video and the record and the video system. So we had to remove the video system such that we're able to conduct the stimulation in 1 room. In the 1 room setup, we're both doing debriefing and scenario in the same, but the content remained the same. This is a simulation center in Mulago Specialized Women and Neonatal Hospital. In the first, on the left side is the trainer with the model. That is where the scenarios are conducted. In the next one is where the trainer is interacting with medical students, and that is the debriefing room. So that is the traditional setup. Now this one is the one still at Mlago. I was with the principal investigator still in the same room, and the mentor specialist, Dr. Namagembe, trying to see that the things go well. So we know, oh, that is Mlago, Kawempe has a bed capacity of 200 beds, and he delivers that per annum. So we conducted this training from 15 February this year to 30th June this year, and a total of 239 health providers were trained on management of PPH preeclampsia, so that the social and neonatal resuscitation. And we're training the groups of 2 to 15. That's the number of the physicians who went through 12, pediatrician 2, and the majority anyway were midwives, followed by SHOs, and the least were the pediatricians, because they are usually few. We found that in a one-room setting, there is usually unnecessary disruption during the training. The one-room setting is good in that if you're in the center and you have limited space, you can use it very well. It is also cheap, suited for groups, smaller groups. It promotes interactive discussion and effective learning as per the PAL model of simulation, promoting excellence in simulation training. That's what it means. It is good for training for in-service health providers, and with minor technical adoption, one-room setup is suitable to conduct technical and non-technical team communication and leadership. We use, where resources are limited, it's good for in-service training for healthcare providers. And I acknowledge Training for Life from Netherlands, Rotary Club of Chambogo, Makerere University College of Health Sciences, Administration of Kawempe and Mlago, and the Ministry of Health, and all the midwives who went through this training. Thank you for listening to me.
Thank you, Dr. Antuyo, for that presentation. Humanistic learning, I think, is the way to go for competency-based training. So next up is a presentation on FENZA, and it will be done by the speaker. Okay, so FENZA, I think all of us have some literature on FENZA on our tables, and we're just going to go through what it is and what we can learn from it. So nutrition is the foundation of life, and most pregnant women usually have difficulty meeting all the nutritional requirements. So someone will say, why can't you just do diet? Sometimes you may not be able to get all you need in terms of nutritional value from diet, and hence you may need some supplementation. This is also a vulnerable period because what the mother takes in will determine the child's nutrition, growth, health, and development outcomes later on. Although healthy and varied diet remains preferred, we find that sometimes because of pregnancy, it may be difficult to meet these needs in just diet alone. And we know the physiological changes that occur right from first trimester, where someone has emesis, nausea, they do not take in enough. And then in the second and third trimester, especially in the third trimester, you find that the uterus is so distended and they have early satiety, so they will not take in quite a bit of food. In the third trimester, we have increased needs of some minerals and micronutrients like calcium, DHA, and the other caloric requirements. And we know that especially in the left trimester, this is the time when the fetus is rapidly putting on weight and building the stores, its stores later. So supplementation with multivites and minerals plus DHA among pregnant women can actually complement dietary intake. So let's look, earlier on people are saying that we need to look at a life course. So let's look at a woman's nutrition across different stages of life. Adolescence, and we are approaching the holiday period, and most of you will realize that at this point they have high amounts of energy that they need, high amounts of proteins and micronutrients because the time of rapid physical growth and development. When we come to the preconception period, women need to have a nutritious diet to protect their health primarily, but also come up with sufficient stores that will carry them throughout the pregnancy. During pregnancy, because of the fetus and the physiological changes that occur, definitely the energy needs go up. And when we come to the breastfeeding moms, especially in the first 6 months where they're breastfeeding exclusively, the dietary requirements actually increase by 640 kilocalories per day. Global prevalence of malnutrition in women, this is unacceptably high. Unfortunately, it is seen in settings like ours in sub-Saharan Africa and South Asia and other low-income countries. And we know that women's diets are poor and already deficient in micronutrients. So here we're looking at the undernourishment and the overnourishment. So a bit of statistics, 9% of the women globally are underweight, meaning their BMI is less than 18.5. Close to a third are overweight. So if you look, when you're on the table, if you're 5 women, probably 2 of you are on that side. 7% of the women aged 20 to 49 have a short stature, and anemia is still prevalent at a third. So what's the importance of nutrient supplementation during pregnancy and childbirth? We see that there is an increase in the red cell mass, an increase in the body volume, an increase in the plasma volume, and all those translate to an increased demand for nutrition. If we look at the different micronutrients, beginning with folic acid, we'll see that, and most of us prescribe folic acid. And why are we doing this? Because we want to reduce the risk of birth defects that affect the spinal cord. We know that it's essential for blood and protein for the baby, and it's very essential for brain development and rapid cell growth. Calcium, as we know, is important for the teeth and bones, the heart, the nerves, the muscles, and plays a role in prevention of preeclampsia and osteoporosis. Iron is very important in preventing anemia and related side effects. Some of these are usually not talked about, but they are very important. Magnesium and copper. So magnesium, it can help in prevention of preeclampsia and reduces maternal and fetal morbidity. Copper is a very good antioxidant. The other good antioxidants we have are vitamin C and vitamin E. And the other multivites, the B vitamins are very important for metabolic processes. We do not want to see children that are in that slide. Hence, we need to prescribe folic acid. DHA is a critical component of cell membranes in the brain and retina of the baby. It's an omega-3 fatty acid that's found in fatty fish and fish oil supplements. And it's and we know that 60% of our brain tissue is actually fat, and DHA accounts for 36%. So during the last trimester, the fetus will usually accumulate about 67 milligrams of DHA per day. So the mom actually needs to have this in her, either as a diet or supplement. Sorry. So DHA is crucial for the developing fetus. Someone needs about 100-300 milligrams daily to cater for the needs of the fetus. And it helps in visual and cognitive development of our unborn child. The other things that it does, DHA prolongs gestation, and because it prolongs gestation, you find that you have an increase in the birth weight, it prevents preterm birth, and actually improves on the fetal immune process. Benefits to the fetus, DHA, increased visual acuity. So people are having issues seeing the projector. So DHA, mother who takes DHA, the fetus has better, the baby, the newborn baby will have better visual acuity. There is a favored mature neonatal sleep state. So we've seen mothers coming in and saying that the babies are crying the whole night. They were not able to sleep. So DHA helps with that. Reduced hyperactivity and prevents ADHD. And of course, a higher IQ. Now, many times when we talk about omega-3, the first thing people will think about are seafood. Okay, maybe those who can afford. But in 2004, FDA actually advised all pregnant women to limit the amount of seafood they were taking. And this recommendation was later taken on by AOGU. And the fear here is that the seafood has an increased amount of mercury. And so the pregnant moms need to limit how much seafood they take. The other mineral that we see is zinc. Over 80% of women actually lack it. And the low levels have been associated with pregnancy complications and preterm, and hence supplementation with zinc is extremely important. I am the chair, so I don't want to flout my own rules. Okay, so there are pregnancy complications, and we have seen the statistics, but I just wanted to highlight that alcohol consumption is still high in our community. Preterm birth is a really major source of our babies dying young. And in Uganda is ranked the 28th worldwide in preterm births. Very high number of births, over close to 1.7 million births. And we see, when we look at the deaths in the babies, most of them are neonatal disorders. And why? Because malnutrition is really, really high up there, and it may lead to some of these. Now, Mega did a survey among 200 gynecologists, and I'm sure some of them are in this room, and we're asking some questions. Yes, whereas we know that 25% of teenagers get pregnant, over 49 of us say that the statistic is only 10%. What does this mean? That we need to have knowledge of our statistics as a country. 35% of the doctors said yes, women need to be aware of the right nutrition and other parameters. And 10% actually thought that pregnant women actually consume alcohol. So we need a solution to these problems, these many problems. And so FENZA is what we have there. It is a comprehensive supplement that has multivites, antioxidants, and trace elements, and pregnancy essential elements. And the take-home message is that for enhanced care throughout pregnancy, breastfeeding, for a healthy development of the fetus and newborn, you need to take FENZA. It's advised not to take this medication within 1 to 2 hours with other drugs, and it should not be taken with milk. So during pregnancy and lactation, those are the benefits that we see from taking all these multivites. And I will skip that. And say that DHA along with multivites in a single capsule is very good. There's high compliance with no fishy smell and patient-friendly forms of zinc and calcium. So for adequate nutrient supply before, during, and after pregnancy, that will help in curbing impact on diseases in later life of the mother and the baby, please prescribe FENZA. Thank you. So the last person in this segment is Dr. Esiru, that I would like to invite to the podium. He's a consultant obstetrician and gynecologist that is supporting the RMNH CAH mentorship program in Karamoja region. in partnership with the Ministry of Health and doctors with Africa program. He's a former national coordinator for the PMTCT program in the Ministry of Health, and he's very passionate about mentorship. Please, Dr. Esri, you're welcome.
Yeah, thank you, Chairperson, for the session. Good evening, colleagues. I've been introduced. I want to share with you preliminary analysis of that is taking place in the Ministry of Health, and I'm making this presentation on behalf of Dr. Dan Morokra, who is the Reproductive Health Advisor with the AMCHIP World Bank funded project in Ministry of Health. And they're trying to assess the impact of the mentorship program that was conducted in the country. Now, as an introduction, in 2021, 7 CSOs were engaged by the Ministry of Health One Back collaboration to train and mentor health workers in 7 regions in the countries in the various RAMCA skills packages using innovative mentorship approaches. These CSOs partnered with the Health Professional Association, with the districts they were in, the regional referral hospitals, to train a pool of regional mentors who are then deployed together with the representatives from the Health Professional Associations and the regional referral hospitals to do mentorships in various health facilities in the regions they were mentoring. And we all know that training and mentorships of health workers using innovative mentorship approaches that are results-oriented are very essential, as has been mentioned by the previous speakers. And this program was trying to kind of address the suboptimal coverage of priority high-impact interventions in our country that have led to a high burden of preventable maternal and newborn mortality rates in the country. Now, after the mentorship program, Ministry of Health set out to document effective approaches to competence-based RAMCA clinical mentorships and their impact on the skills acquisition and retention in the 7 participating regions. However, these are just preliminary results. This is an ongoing work, so I'm just sharing the preliminary results of what has been analyzed so far. So the Ministry of Health is reviewing the monthly and quarterly progress reports that were submitted by the various CSOs to Ministry of Health, as that was one of the requirements. And then they are documenting a mix of innovative approaches that were engaged by the various CSOs. They are also documenting the number of healthcare workers that were reached by the respective CSOs, as well as the competencies based on the marks they got before and after the mentorships. And then also they're downloading some data from the DHISU to corroborate the findings and the improvements in some skills packages from the respective regions. So this slide just summarizes the various packages that the CSOs mentored the health workers in. They range from packages of helping the mother survive, helping the baby breathe, infection prevention, integrated management of childhood illness, integrated family planning, adolescent health, MPDSR, continuous quality improvement, data analysis, post-abortal care with a focus on MBA, among others. Now, the various mentorship approaches that were documented, that were used by the various partners included traditional offsite group-based training, placements and attachments of the health workers to the centers of excellence that were existing in their regions, hands-on practice and clinical skills laboratory, emergency drills, on-site stimulation-based low-dose, high-frequency approach using the hub and the spoke model, clinical skills transfer surgical camp. This was specifically done in Karamoja. And then other partners used the e-mentoring, videos, online learning session, and as well as use of social medias. Many of them use standardized job aids, flip charts, and action plans to standardize the process. And some of them actually cluster the health facilities in their region for easy mentorship and coordination. And then they plan together with the district, and they deploy the mentors to mentor these the healthcare workers on site, which lasted between 2 to 3 days. And then for assessing competence gain and knowledge acquisition, they use standardized checklists before and after the mentorship to see whether there was improvement in the skills gain and retention. Those photos show some of the mentorships of the healthcare workers taking place. Now, just to try to summarize the results, in terms of improved competencies and skills retention in selected maternal skills care packages across the 7 regions, the red bars actually show the scores before the mentorship. The green bars show the scores after the mentorship, that's post-test. And then the blue bars actually show the knowledge gain across the 7 regions. So you do see from here that the greatest knowledge gain was gained around area of manual vacuum aspiration, where the knowledge gain was about 34%. This was followed by postpartum hemorrhage with the knowledge gain of 21%, followed by pathograph use with the knowledge gain of 18%, average across all the regions. And the cesarean section was the least with 11% knowledge gain. That was around maternal packages. Then also they have looked at selected neonatal care packages. They looked at care of the sick newborn, newborn resuscitation, and essential newborn care. Again, from this, you see that the greatest knowledge gain in newborn care packages was around newborn resuscitation, where the knowledge gain improved from average of 49 to 84%. This was followed by care of the sick newborn, which increased by 24%, and the essential newborn care increased by about 13%. This slide is a bit crowded, but again, they looked at the various different indicators, use of a pathograph, active management of third stage, PPH, PET management, and assessed the performance by region. But I just want to focus the attention to the last column, the averages. So you can find that you see from there that there was some improvement across in the use of the pathograph and active management of third stage. Actually, the score was above over 80%. But in the area of PPH and PET, there wasn't significant gain in knowledge. And yet these are the leading killers of maternal, leading causes of maternal. So again, this calls for increased vigilance in the great skilling around these packages. This one is just an example illustration from the program that was in Southwest Uganda on the use of a pathograph, and it shows increasing trend in the use of the pathograph from Q1 up to Q4. This was around other indicators around care of the newborn. So this is around proportion of women with the at-risk sepsis who are properly managed. Then there was preterm management and the complete essential newborn care. Again, the least area that there wasn't much gain was around preterm labor. So again, this is again an area that I think we need to focus on and try to skill our healthcare workers on how to manage preterm labor. And then the other, from this slide, I think the take-home message is that we also looked at the proportion of health facilities that conducted at least 2 emergency drills per month. And again, Minister of Health is interested in making sure that sites actually do conduct emergency drills. This was quite low, below 50%. And again, I think this is an area where we probably need to interest our facilities to do. This is my second last slide. We also try to pick out some of the experiences from the various CSOs around
leadership and governance on maternal and newborn care. Many of the reports show that the teams had MOUs, the CSOs had MOUs with the various district leaders, and this provided a critical leadership authority that was required for the success of the mentorship program. The CS also, many of them really did a very good coordination role where they were able to coordinate the various representatives from the health professional associations and were able actually to make the mentorship program successful. The regional referral hospital directors actually did a commendable job, and the heads of department were very supportive, and in most of the reports that were reviewed, they were actually supported the program. However, I think if we are to sustain this, they would still need to build the capacity around the regional referral hospitals to coordinate this mentorship program. And then again, there was a great support from the professional associations and the consultants that were recommended by the professional associations that were really very helpful. And I think we want again to commend the role the associations, the professional associations taking through this. And then site leaders and the facility management committees were critical in mobilizing mentees for the mentorship program. You realize this was an on-site mentorship and a lot of advanced preparations was necessary for you to be able to get the mentees on site. And then we also appreciate the technical leadership that was provided by Minister of Health through the NASMEC committee. And in conclusion, as I said, this is an ongoing work. These are just preliminary results. Minister of Health is still continuing to analyze the various indicators to see what impact they cost. And I think this is intended to inform the continuation of this program. So in conclusion, I think these innovative mentorship approaches used by the various CSOs improve the quality of some of the MNC services, as we saw in some of those slides. But there are some areas that need continued mentorships, especially around PPH and PET and management of preterm delivery. Standardized and technical evaluation tools as well as mentorship approaches is critical in realizing better mentorship outcome. We also know that leadership is a critical ingredient for effective mentorship program, and mentorship programs require dedicated coordination, organization, and demand creation in sites for them to be successful. So I want to acknowledge those who are the CSOs that were engaged, AMREF, ACHEST, QAM, JAPIGO, SAMASHA, SDS, and THINK. And Zenis, we really appreciate the role you played in building the capacity of the healthcare workers and the rest of the stakeholders there. I thank you for listening to me.
Thank you, Dr. Isiro, for that presentation. At this juncture, I would invite questions from the audience. If you have questions, kindly raise your hand and we'll bring the mic to you.
Thank you very much, Dr. Siru. Very, very impressive work that was done and the results, but challenges, could you just highlight them? Don't need an explanation because it was quite good, but we need to know, people need to know the challenges that we met, or that you met while you're doing all this work, because it's quite ambitious.
Any other questions?
Yes, thank you very much. And I want to thank all the presenters for these lovely interventions. My question is addressed to Dr. Lawrence, and that is really on pain management. And I would want to know his opinion on what is being done in the different health facilities that we manage regarding pethidine versus morphine in the third tier. in management of pain and his opinion on how we can possibly also decrease the use of bupivacaine vis-a-vis intrathecal morphine. Thank you.
We'll take 3 other questions.
Thank you. So my question is about the dose of folic acid for prevention of neural tube defects in pregnancy. The recommended dose in the CDC, the UK, WHO grams daily. And I noticed that Fenza contains less than that. It contains 0.25, so that's 250 micrograms daily. So I wonder now, why are we promoting a product that doesn't contain the recommended dose of folic acid for prevention of neural tube defects in pregnancy?
Yeah, thank you very much, the presenters. My question goes to the midwife, Sarah. I thank you for the innovation you are doing in monitoring labor. So I wanted to find out really, during monitoring, what was the failure rate? Maybe how many mothers maybe failed to deliver during the time of monitoring using the stool? Or really, I don't know whether you have a number actually, who have failed, who ended up maybe in theater or maybe vacuum, something like that. Thank you.
Any other questions? Okay, so I think we'll allow the presenters to respond to those questions, beginning with the one regarding the dose of folic acid. Yes, I agree that the recommendation is 400 micrograms, but then you'll find in most of these medicines that have a lot of micronutrients within them, rarely will they have that dose. But yes, it's true that the recommended dose is 400 micrograms and not the 250. Yes.
Thank you very much, the delegates, and thank you very much for the question from Dr. Romano, Prof. Romano Ayarhanga. My experience with petidine morphine use, we know these are drugs, opiates, drugs of that I used to manage pain, especially in step 4. The experience is that we know these are drugs of dependence because there's that reward system and the tendency for people to get addicted to them. So following the curriculum, following the guidance from Minister of Health, and also the people who have authorities in this kind of neuropathic pain and the cases that are especially via to that use of such medicines. Well, I would seek guidance from especially the team in Uganda that is in charge of such managing such medicines like morphine and petidine, the hospice team, for cases that require this kind of medicines to try and numb the pain, for especially in the palliative process. For some of us who are using these medicines postoperatively, we recommend that we don't use more than 3 doses, especially of petidine, because with time, this is where we are seeing most of our clients starting the whole process of getting addicted to the petidine and morphine and fentanyl. Probably using this medicine, or if we can use the scale in consultations with anesthesiologists to find the alternatives to these medicines. We have parenteral paracetamol. If we have worked on these patients under spinal anesthesia or regional blocks, we would recommend some of these molecules, like one I've talked about today, paracetamol efavirenz. They can really dissolve this in about 200 ml of water in a glass and then take to handle the pain. The other question I didn't get very well about petidine, I mean the bupivacaine. I didn't get very well, probably I'll just come to you and we have a chat on that.
Yes, thank you so much. I would also like to respond to the question of the failure rates. Sorry, I was caught up with time, but I was supposed to have, I was presented the preliminary results of this study, but the results clearly show that there is, in regard to the birth positions, there is increased stool birth. There used to be most of the dorsal, in regard to the positions, there used to be increased 100% dorsal positions. Data is collected. This is day data, which we have a data collector who picks this information, this data on a day-to-day basis. And then the monthly data clearly shows that there is increased birth on the stools and also increase in the use of lateral positions. And the dorsal positions, there's a marked decrease in the use of the dorsal positions. And the women actually acknowledge the benefits. They feel good about these other positions more than the dorsal position. So then still in that regard to the emergency C-section, you know, it's a referral hospital, but at least the day-to-day collected data clearly shows that the increased vaginal births, on a particular day, you find that there's so many more than the cesarean sections. And so that is so far what we have. And then of course, there's reduced augmentations because of those emotional support, which also releases the oxytocin. Yeah, the calm, you know, those strokes and all that. So there's some bit of reduced. So we have the preliminary results. Unfortunately, I didn't present them, but so far that is where we are. Yes, the failure rate, the stools, of course, some people, most women really like the stool. And maybe what I can't really call it a failure rate, but we've been monitoring, and the documentation clearly shows that the women are opting more for the stool and also other positions than the dorsal positions. Thank you.
Thank you so much for the question. I think I had one question from Dr. Salongo about the challenges met. Unfortunately, as I said, this is work ongoing. These are just preliminary results. And I imagine that once this assessment, this analysis is done, they will then also include a slide on the challenges. But I'm aware that various CSO met various challenges. However, what Minister of Health informed me is that they are experiencing a challenge of comparing the performance across the 7 regions because of the varying M&E frameworks that the CSOs used. But I also know that the M&E framework kept changing as we are implementing this. But I want to believe that once the analysis is done, they will definitely include a slide of the challenges that were encountered. Thank you so much.
Okay, so thank you very much to our dear presenters. A round of applause for them. So as you can kindly take your seats. So as we conclude this session, we have 2 raffles. The first one is going to be by Saito, and you have a maximum of 5 minutes. Flores.
Three minutes. So thank you very much, Dr. Susan Haire. Kindly, can you that will be given. Select out a winner